See a lot of head nods out there. If you take a look at the agenda real quickly, you'll notice that we have some written only, and I would urge the members, those here and those on WebEx, to be sure to read these documents because these are responses to questions that we had at our last Bob Bethell meeting. We're going to start then on page 2. And Suzanne Luker, I'm afraid, has had a family issue, so an unexpected event this morning. No, she will not be with us, so we're going to begin with Haley. Welcome, Haley. And you have about 15 minutes if you don't need that all of that time. That gives us more time for questions.
Very much take the hint. All right. Good morning, Senator Gossage and members of the committee. My name is Haley Ordoin. I am here as the long-term care ombudsman, and I do have a presentation for you. I understand it doesn't convey the best on WebEx and the screen, but you have it in front of you. So I just kind of wanted to go through that. This is a little bit more of our detailed report. And last time I was here, I kind of gave an overview of our office and what we do, what we're here for. But so I wanted to kind of dig into a little bit more of the meat of our office throughout this year and give you a little bit more detailed explanation on some items. So if we'll follow along here, this is the actual official copy of our annual report. So if you have more time or more interest, please feel free to go through that. All right, I am skipping to page 5. Just kind of a little bit of detail here, talking about how we are structured and the layout of us here in the state, because we are an independent agency. So we are directly underneath the governor. We do receive some support through KDADS, that's our source of federal funding. And then the Department of Administration provides like our IT, our HR, and all those things. But we do have 12 certified ombudsmen. And then underneath that, we do have 10 volunteer ombudsmen. A couple years ago, pre-COVID, that number was about 150. Obviously, for obvious reasons there. That number did dwindle. We're hoping to continuously recruit individuals to help us with our cause of advocating for residents in long-term care and adult care home settings. All right, next page. This talks a little bit more of what I spent our time with last time, of the functions of our office, and just kind of a quick reminder, we identify, investigate, and resolve those complaints made by or on behalf of residents that live in adult care home settings. So we do not go into independent living and nursing facilities for mental health, but a lot of the other settings there we do. Talks a little bit more about our function and responsibility in detail there. All right, a little bit more detail is our service to Kansans this last year. So for the 2024 year, we investigated over 1,000 complaints made by or on behalf of long-term care facility residents, and we resolved or partially resolved about 58% of those. Now I will state, somebody might ask, well, why aren't they all resolved? Well, sometimes there are certain situations that the resolution would be enforcement by KDAD's agency of penalties to a home, and that's outside of our jurisdiction. So we try to resolve the plan of what we go into is we have a complaint. We go in and we investigate to see what the wish of the resident is that we can resolve it to. Our regional ombudsman try to resolve that there. If they're unable to, then I step in and try to coordinate, work together with the providers, with the family, whoever the issue is with. And then if we need to refer to outside agencies from there, we do that. With KDAD's, a surveying agency, sometimes KDHE we utilize for Medicaid issues, sometimes Adult Protective Services we utilize referrals if the individual that is the source of the complaint or the cause of the complaint for the resident lives outside in the community. Sometimes we involve APS for that. So we utilize and refer all those outside agencies. But we made 2,328 facility visits to adult care home to meet with the residents. Sometimes that's based off of a complaint. Sometimes that is based off of just what we call routine access visit. We try to get into each home quarterly. That's our goal. The minimum requirement is annually, but I'm not satisfied with annually, quite honestly, under my direction. So we try to go in quarterly. We support residents and families through self-advocacy by attending and providing support to 95 resident and family council meetings. We definitely want to increase that this next year. We provide information and assistance to over 2,000 individuals. And what that is a lot of times is just what it states. They call, they ask about, I'm not sure who to go to for this. I'm not sure if this is something that we can resolve. It doesn't turn into a case. There's no investigation. It's just, hey, here's who you need to call. This is the number. This is the agency. This is who can help you out. And we also do that too for facilities and facility staff. So we go in and we provide resident rights information, resident care, family conflict, all the things listed there. We provide education to them. We completed 10 facility staff training sessions. We certified 3 new ombudsmen. And then we also coordinate with KDADs when we can to attend their surveys in the facility, and we were able to do that 255 times throughout this last year. I do want you to know at the bottom there, it talks about the number of people that we serve. So we have 298 nursing facilities that includes a little over 18,000 licensed beds. 504 RCCs, that includes like your assisted living, Homes Plus, et cetera. That's over 15,000, closer to 16,000 licensed beds. So we really serve a total of over 802 different homes and close to 34 licensed beds. Sometimes that's at capacity, sometimes it's not. But that's a lot of people that we serve. I did include in here our map of our regions, along with, I'm a very visual person, so the next page, you have faces to names of our staff for who they serve. This is also available on our website, but these are our regional ombudsman, our special project ombudsman, Barb Hicker, and then myself. All right, page 10 goes into our ombudsman activities, and this just kind of divides up the complaints of where we get them. And so you can see orange is our highest area. That's resident rights. That includes abuse, neglect, exploitation, admits, discharges, dignity, retaliation, choices not being respected, moving back to the community. Resident care is the yellow area. That's more of your day-to-day activities of daily living, accidents, falls, restraints, conflict resolution, food, etc. The green area is your facility environment and administration. Excuse me. That is really, physical environment, supplies, accessibility, concerns with leadership, staff turnover. And then the smallest area, that red, is non-facility, and that's issues like Medicaid, managed care organizations, other insurances, or different providers in the community. And this page just goes into a little bit more of an explanation of the types of assistance we provide with what is information and assistance, how do we attend the family councils and resident councils and help out there, how do we outreach to the community and provide education, and how we do the survey participation. All right, page 12 gives very precise numbers. It breaks those down even more so into the different categories and types of complaints and gives you the precise detail of the numbers of those. All right, page 13 talks too about who are the complainants at the top. So the majority of the time, about half of the time, it is the actual resident. And then, but anybody can be an individual that provides a report. Any of us in this room can report an issue or a concern. And the process is still the same. We always go to the resident to determine if they can give consent for investigation or what their wishes are. If they're not able to, then we go to the substitute decision maker, the power of attorney, the guardian. But that's kind of, the top is the mix of that. Half the time, like I said, is the residents. Then the next is the family, friend, another representative. Our ombudsman's program, we can make concerns ourselves, make reports if we see something concerning other individuals out in the community. And then sometimes we do have facility staff that will contact us out of concern. And then below that, the pie chart there just goes into complaint resolutions. The majority of the time we're able to resolve them. As I stated before, some complaints are not able to be resolved because they require outside services from different agencies. Okay. Page 14 talks about care issues, and that's 1 minute left. All right. Boy, 15 minutes goes fast. Okay. You can read a little bit more on care issues. I wanted to hit on a couple different topics. Staffing. Staffing is really a huge issue. A lot of what our complaints focus on, meaning heavy dependency on agency staff, staff refusing to provide needed care, lack of training and competency, and not knowing the resident and their unique needs. When we have agency staffing, a lot of time, what we get complaints about is not knowing that person, not providing the individualized care. I did provide for your reading pleasure, and I plan to reach out to every single one of you now that session is over to hopefully meet this off time to go a little bit more into detail and talk about any of your questions or concerns with our office. I think it's important for you to know our functions, what we do, what we don't do, how we help, and the issues that are really facing the individuals that reside in the long-term care home setting. You can read here some of the systemic issues. 1 minute's not enough time, but there's a lot of challenges that we have, such as misuse of psychotic medications, facility-initiated discharges, closures, challenge with abusive guardianship, conservatorship, and the durable power of attorney, and insufficient staffing in the workforce. You guys have been hearing that, I know, for many years because I've been part of you guys hearing that. And then we do have, I don't ever like to come with problems without resolutions. So further in my report here, we do have some opportunities that I feel that we can resolve some of these and where it starts and where our focus needs to be. That is between pages 15 through 19. We're obviously going to consistently advocate for increasing the ombudsman's staffing numbers, increasing KDAD's surveyor staff, some issues with pharmacy provider choice. We have some homes that are charging individuals $200 to $300 a month for administration setup for medications if they choose to utilize an outside facility other than their contracted provider, and then an increase in personal needs allowance. I don't know about you, but I don't think $62 a month supports a lot for people in a home. I know a lot of their care needs are taken care of, but as one resident stated to us, I don't really like going to a thrift store to purchase used underwear, and that alone, you know, things are expensive. Underwear, a haircut, $62 doesn't go very far. So I would recommend reconsideration of that. And as I know my time is probably definitely up, there's a lot more detail in here I'd love to go over with you, but we're gonna save that for the appropriate time, and I'm here for any questions I can answer.
Perhaps those will come up during the questions. Committee questions for Haley. Yes, Representative Bryce.
Thank you, Madam Chair. Thank you, Ms. Luker. I just had a quick question. Maybe there's data or maybe you have a feeling. It seems like the most efficient way for these complaints to be resolved is for the family or the patient to approach people at the facility locally. Do you have a feel for, do they go that route first, or do they go to you first and then you get them involved? Or is it mostly they approach the facility and the local people and they don't get resolution, so then they go to you? Just wondering. Thank you.
Happy to answer that question. Thank you for that. Yes, a lot of the time, by the time they come to us, it has gone through the grievance process. Not always, I will say not always. A lot of it's relationship building and kind of who they feel comfortable going to sometimes. So sometimes it is independent to us and they come to us straight right away. Sometimes they have exhausted the grievance policy in the process through the homes. Sometimes when we go to the homes, they claim, hey, we're not aware of this, we don't know. So we try to just work to resolve that right then and there so that it doesn't need to escalate. We don't need to utilize any outside resources. But I would say for the most part, most of the time, the grievance policy within the homes has been already attempted.
Thank you for that. Thank you, Madam Chair.
Other questions, committee? Yes, Representative Bueller.
Thank you, Madam Chair. I'm going back to the staffing. There's a little bit of a personal reason for me asking the question is when it talks about staff not knowing or being given the wrong medication, what type of, what's common with that, that complaint? How does it arise and what is done to resolve that?
All right, thank you for asking. A lot of the times what we receive the complaint about is it's related to medication, and it kind of ties in a little bit too with the antipsychotic medication. What we get complaints for is missing medication, not being passed, being the wrong person, given the wrong medication. Where that ties in with staffing is that very frequently, not every single time, but I'm gonna say very frequently, what we find it to be is that staff is not familiar with the people that they're caring for, and then therefore, that it's very task oriented. We're trying to get the medication passed, and we don't check, the 5 Rs. We don't check, all the things, and the resident is receiving the wrong medication, or the staff is behind in their care, and so the medication is giving outside of the time of the parameter or really late. But that's how we get the complaint for that, and a lot of the time it does arise from just the staff not being consistent staff there for people. It's someone, that an agency sent for that day that doesn't know the resident, doesn't know what's normal for them, and, a computer can only provide you so much information.
Representative Carpenter.
Thank you, Madam Chair. Haley, thanks for being here. So in the past, we've had some issues with eligibility and redetermination. Is that getting better? A lot of times what's happened is someone has taken on a person and they presumed they were eligible for Medicaid, and then, they find out there's a problem with their eligibility or something like that, and they need to be reimbursed for that time frame. Mm-hmm. Is that better, worse?
So here's the tricky part of that. And we collaboratively attempt to work with the providers, because that's really, at the end of the day, that's who it's really affecting the providers. Yes, it affects the resident, obviously, because then they can get a discharge notice for non-payment if they're determined not eligible. I will say that KDHE has been wonderful with any time I contact them saying, hey, can you check this? Can this be expedited? Where are things at? They have been very collaborative with us in trying for that. I will say that I think it's gotten a little bit better. I do. But we still do receive complaints from homes saying that, we admitted this person Medicaid pending with the intention that they were going to be improved, and they're either not. I will say a lot of the times what we do run into kind of at the root of the investigation of that is that they either have nobody to help them with the application, or that the guardian or power of attorney is dragging their feet and not providing the information in a timely manner. So then we try to collaborate and, get them to do that more so. I will say, I think more often than not, it is not so much the processing time that is the problem as it is collecting the correct data and information that needs to be submitted for that. So at the end of the day, we do try to step in and help resolve that as quickly as we can, because we don't want to see a resident get discharged. Even if they get the discharge notice, oftentimes there's not another home that's going to take them knowing that, or there's not an appropriate location for them to discharge to, so it's not a safe discharge. So it's really something that needs resolved, but it's oftentimes not the processing and eligibility fault. It's more so that there's missing information to complete the application.
Thank you for that. We don't have control over that part of it, but we do have control over the eligibility part, and what we have control over is more where I'm concerned.
Yeah, I will say that the part that we do have control over is, and I know there's a lot of work done this session, and I thank you all for that, on the guardianship. The Universal Guardianship Act there is holding the guardianship individuals accountable, holding the guardian conservators accountable for that information. Then you have the other part that's the power of attorney, and oftentimes, that's family member, and we don't have too much control over that.
Very good. Thank you. Thank you, Madam Chair.
Representative Ballard.
Thank you, Madam Chair. I'd like to follow up on a previous question on staffing. All right. You responded what kinds of incidences would cause it, but how do you follow up on that? For example, if someone is giving someone the wrong medicine, actually somebody could die as a result of that, or a conflict with another kind of medicine that they have. How do you follow up with that to see that that is not happening, even though they may be new and inexperienced?
Yes. So thank you for the question and the follow-up opportunity there. What we do, that's kind of where it gets a little outside of our jurisdiction, and that's where we bring in KDADs and the surveying agency. This is why we are advocating for a funding increase for them, for their staffing too, and expanding to hire outside, licensure types to bring in more individuals for their surveying staff, because ultimately that's then on them for the, I don't want to say the penalization, but that's really, where there is, to hold any sort of weight to those sort of issues to try and have any correction. Because otherwise we'll come in, we will investigate, we will resolve, but then ultimately, to have any sort of consequence to improve it, it's really on the state surveying agency and CMS for their licensing authority.
Sorry. Is there a follow-up? How do you know that they're doing something about it?
That's the really tricky part, because basically what we receive or what the individual receives at the end of the day, I mean, KDEDS is really good about communicating to us if we, reach out and ask, but while they're doing the investigation, it takes time. And I will say, and they'll admit themselves too, it takes time. They don't have adequate staffing to go out there for it to, they prioritize, they have an escalation chart for their stuff, but just like, for example, and this isn't medication related, but think of a bed. Think if you're paralyzed and your bed is malfunctioning, okay? It's going to take them at least 2 weeks to get out to investigate that. So that's where, we have tried to step in and escalate it on our end to try and resolve. But for medications, it's really, they go out, they investigate, we can ask and follow up where things are, but ultimately it's a notification sent of, this was found to be in compliance, out of compliance. There were CMPs issued, there weren't. That's kind of really the final resolution of it. So it's not to our liking, and that's why I say some of our complaints aren't, resolved based on that.
Senator Erickson.
Thank you, Madam Chair. Thank you so much for your presentation. Just a quick question as I sit here listening to this, and through my own experience with my parents, who I believe received excellent care during their time. Is there any tracking of quality of care, complaints, and family involvement?
Can you expand upon that?
Those residents or those patients who have very involved family members, I'm guessing, do not have as many complaints, and my guess is receive a higher quality of care. Do you work with the families in those? I mean, do you see any correlation, or do you track any data around that? Because I think that's probably key to have an advocate that's a family member or a cherished friend, or someone advocating for that person would be key to their quality of care and their health.
I would absolutely agree with you. I was sitting here thinking of our reporting and our metrics that we track, and I do not believe I have metrics that track that, so to speak. But from personal experience, observation, I would 100% agree with you that the more support an individual has, the more individuals that they have advocating for them, the better quality of care that they receive. And that's why I really think it's vital for our program, especially to come in for those individuals who don't have that, for us to be those advocates in lieu of the family or the friends that would be doing so, to make sure that the quality of care and the level of care is elevated.
Senator Petty, I understand your hand is raised. You're on WebEx with us. Can you hear us?
Oh, yeah, I can hear you. Can you hear me?
We can hear you. Please go ahead.
Thank you, Madam Chair. So, Haley, you in your report, and thank you for sharing that with us. I was just curious, when you talk about resolution, is that so? I was curious, when you get a complaint and it hasn't gone, you find out that the facility didn't know anything about it. Is that reflected in your report?
anytime we get a complaint, we have to ask the resident for their consent to investigate it, to proceed, in trying for resolution for it. Part of these numbers for the not resolved includes and captures when a resident says, I have this complaint, but I don't want action taken on it, or I don't want, very odd. The example I can give you is one that we ran into, and this isn't on the facility, this was on a family member power of attorney. The power of attorney was making some choices that the individual did not agree to. We gave them their options of how to resolve it, and some of it included legal recourse. And the resident stated, this is my child, this is my only child, I don't want to sever that relationship with them, so I'm just going to let things be and not pursue it. And then, that's technically not really a resolved issue, but it's, what they have chosen to do. When it comes to the facility side of the resolution, I would just state that it is included in the complaint resolution percentage. But again, there may be some times where a resident feels that it hasn't been resolved, or we go through the process where we report to KDADS, they come in and they investigate it. And sometimes the tricky thing with that too is that by the time KDADS gets in, it either has been resolved or they did not, witness or can't find findings for the issue that we allege occurred. So then it's claimed to be, unsubstantiated, and that's not to the resident's satisfaction either. So it's considered unresolved too.
Quick question,
just as-
Representative. Sorry, Senator.
I had a follow-up, sorry, Madam Chair. And so, like, for example, what you just mentioned, that does then in any way, does the report reflect if this is a repetitive complaint from, so like you said, either the complainant isn't satisfied with, I guess, the recommendation. Does the report ever reflect that this is a continual complaint from the same party?
So if it is, we don't close it until it is either fully resolved or it has to be fully resolved. So we don't start a complaint, close it, reopen it for the same issue, and do that. I believe that's kind of to the point of your question. It would stay open and we would continue to work on it. We have had some that have exhausted months, close to a year before, but it's all counted as like one issue, one incident.
Okay, thank you so much.
Representative Bueller, you have a quick question?
Thank you, Madam Chair. The bill number escapes me, but in this past session, we had a bill that talked about Alzheimer's training.
88.
Thank you. I'm just curious about any thoughts, progress, or post-session thoughts, if you will.
Yeah, absolutely. I did testify at that. It was a very interesting bill to me because I felt we were already doing what was required. The ACL nationally, federally oversees us and provides requirements for training. So we were already doing such. I did feel, and I brought this up in testimony, that the language of it was more provider specific than it was to our office because we're not providers. We go in and investigate and resolve. So we did feel it was a little bit more provider language, but at the end of the day, we're already doing the training. It's already on our agenda for our annual training. We support it. I mean, who wouldn't support better education and dementia training for anybody that has dementia? I mean, I'd love to see the public educated better on that too. So yes, we support that, and we're happy to continue the training for our staff and for our volunteer staff also.
Representative Carpenter.
Thank you again. So under opportunity here, I'm reading this one part here. I'm going to take a shot at this. I see so many acronyms, and I probably know about 1,000 of them, but DPO A is
Durable.
designated power of attorney. Okay. So explain to me what that means. What they haven't even met the criteria to be active.
Okay, so
Explain that a little bit.
yep, I am not an attorney. I like to argue like one, but that's where that's where my experience lays there. What we find is that there's so many different types of power of attorneys, and every single one that's written is very specific. A husband and wife can have two different ones. There are different types to where they are in place immediately when that person signs. There are certain instances where it springs into effect based on certain circumstances. Incapacitation, there are certain ones where it states that a court or two medical providers have to deem this person incompetent. There's different requirements for when it becomes effective. And what we find is that we have a lot of individuals, providers, et cetera, that just see they have a power of attorney. That's who I'm going to for everything. And it skips over the resident, it skips over that individual. It kind of strips them of any decision-making or any say into their care. We've had a lot of issues with that to where the power of attorney or the guardian will say, this person can't have this visitor, or they can't go outside, or they can't do this, they can't do that. And it's like legally, it's not in effect yet because that person has not been deemed incompetent. They haven't had a medical issue to where it needs to be activated. And the resident and their rights are really just being skipped and ignored.
Thank you for that.
I have the last couple of questions before we move on. One is, when we were looking at the questions that you receive, I'm imagining that many of those would be, does my mother qualify for Medicaid? Because they see long-term care ombudsman. And so do you just automatically send them to that department?
Yeah, we do. We do a lot of referrals to the KanCare ombudsman if they're already on, if they're having reprocessing issues, things like that. Or we refer to KDHE for the application processing. We try to just point them in the right direction.
So the reason I usually let members go first is they've asked several of the questions that I had written down, so that works out great. On the picture that you, or on the map that you have for us, and then below the map was a group of pictures, which were very helpful, but it says Region 1, Region 6, but the map doesn't indicate what is Region 1 or what is Region 6.
Literally just recognize that, so here.
If you could follow up with us, that would be helpful for us to know if we have questions in our offices to whom we would refer a constituent. And then you say a lack of staffing. Are there certain requirements that you could get to us also as to somebody wanted to apply for a position in your office? What might those requirements be? What kind of a background are they required to have? And then I have the same question that Representative Ballard did about the follow-up. You know, when one is looking for an insurance company, one can go to the Department of Insurance website and look at the number of complaints that they have fielded regarding this particular carrier. Do we have anything like that when it comes to the nursing homes where they can say, before I put my mother here, how many complaints have come in? Do you publicize that at all?
We publicize our annual report. I will say that CMS, and that is if they're federally licensed, some of our homes are not state licensed only homes, do not go with the CMS 5-star reporting. My personal opinion, just me as an individual, is that I don't feel that the 5-star process is even adequate. I feel that's antiquated. I don't feel like it captures the actual quality of care that somebody gives. I tell my team all the time, pretty chandeliers do not give good care in a home. So I don't feel that there is really a good metric system that we have out there that really talks about quality of care. We do have the PEAK program in Kansas, and we do have our own opinions we cannot endorse though either. But no, there's really not, other than I know that Kansas Advocates for Better Care has done their efforts for Douglas County and working to expand that across the state for, a list of providers, but it doesn't have a quality of care rating on there. It's just a lot of self-investigating, which isn't exactly efficient and timely. No, it is
And
not.
I think it would be good, you're the one that gets the complaints. I think it would be good for, at least, you don't have to say what the complaints are, but like this facility had 25 complaints that were resolved, or, you know, and of course, not a complaint that you felt was justified, because sometimes there could be, this building is always cold, you know, something of that nature. And I think that that would be helpful to parents for someone, or children of someone looking for a facility. Committee, thank you so much, and Haley, thank you for being with us. And we're going to move on now to our next presentation from the Office of the Medicaid Inspector General, Stephen Anderson.
Good morning. Okay, it's on. Thank you, Madam Chair, members of the committee. I'm Steve Anderson, Inspector General. I appreciate the opportunity to be here today and talk about the Office of Inspector General. I want to talk about our some of our leads and things. In calendar year 2024, we processed 1,454 complaints, with 18 of those complaints involving allegations of beneficiary eligibility fraud. We've already processed over 400 complaints this year, and that is slightly ahead of last year's number. I also wanted to talk about an initiative we're taking up. We're in the process of filing 36 civil complaints involving nursing homes who provided false information about their bed taxes for the benefit of enriching themselves. And those civil cases are being processed now with the Attorney General's office with support from my staff. So that's keeping us pretty busy, as you might imagine. Our operating budget for the upcoming fiscal year has been adjusted via budget enhancement to allow us to add 3 additional staff members to do Medicaid-related work. We also requested important changes to our statute that would allow us to expand the authority of the OIG to conduct audits and investigations into cash and food assistance programs. I appreciate the members of this committee that help support that initiative. That will help a lot. We're wrapping up a performance audit involving Medicaid reimbursements for schools. It'll be published this week. The scope of the audit include all Medicaid enrolled students who had services billed on their behalf by a local education agency. This was for providers and this was done between January 1st, 2021 and January 31st, 2023. The audit report makes notes several findings and numerous recommendations. And I will say that the response we got back from KDHE as well as the Kansas Department of Education was very positive, and they acknowledged our findings and recommendations. So we had really positive exit conferences with them. I did want to note in the report, we say that the paying the monthly capitation payments, that the Medicaid is paying monthly capitation payments to the MCOs for the same beneficiaries who are also receiving medically necessary services while attending school. The service they receive from the local education agency are paid through fee-for-service, which comes from state general funds. These services could be paid out of the MCO's capitation payments that the MCOs receive each month. The savings for the entire population of students would be approximately $22.5 million per year if they were moved under the MCOs. And that's going to require some changes, but our calculations show that the MCOs are receiving capitation for these very students, and it would move that under them, and it would take that off of fee-for-service. So that would be a savings that we would experience from that. One of the issues we found that it's going to require some further explanation is there was one of the LEAs that used an invalid MPI, National Provider Identifier number, on its claims in the referring provider field. That MPI was issued to a former director of business at the LEA and was used on 77% of all beneficiaries' claims. That individual who requested that MPI had no medical affiliation. That's key. The individual left the LEA several years prior to the audit period. However, claims continued to be filed by the school containing that same NPI number. The LEA was paid $390,542 using that invalid NPI, and therefore we're non-compliant with 42 CFR 455.440, basically because the NPI was assigned to a non-medical professional, so that made it invalid. So those claims should have never been filed, they should have never been paid. So we're looking further into that. And One of the other issues we found, it's going to be reported in the audit, and we've talked about this before in an interim report, Medicaid service providers do not have routine background investigations done on them. Our audit found that 72 of the 231 providers we've reviewed, or 31%, did not have proof that background checks were completed at the time of our request. We also noted that 5 of the schools performed the checks on 14 of the 72 providers after they received our request for records, which to me is an indication they had not done them. We also looked at 231 practitioners who we reviewed, and only 10 of their files contain searches for Medicare, Medicaid exclusion, which basically says they shouldn't be on there. The searches weren't done. It resulted in a rate of 96% non-compliance. They're required to do that. They're required to make those checks to see if somebody's on the exclusion list. Now we're not saying that they were excluded, it's just that the check simply wasn't done. And that's one of those very simple checks that costs nothing to do other than just a few minutes on the part of the school to do that, and it's not happening. So, and I want to talk about an example. I talked about, I started to talk about this last, Bethel, but we didn't get to it. An example of an open investigation that our office is undertaking. We're looking at providers who are billing for what we call impossible hours. And these are people who are billing for over 168 hours in a week. And for those of you who do not like math, 168 hours is basically 24 hours, 7 days for the week. That's how many hours there are. And they're billing for more than 168 hours, so virtually impossible. They also bill for, there's others that bill for an average of 8 to 24 hours per day. Again, virtually impossible. We looked also at the credentials for some of the, for 11 of the providers who had numerous hours billed over. And we also checked their credentials on the MPI registry and appropriate licensing board. We found that 2 of them had expired license and 3 of them had no record of a license at all, but yet they were billing Medicaid and being paid. They billed for over $7 million and were paid for approximately $3.5 million for invalid claims due to licensure issues or impossible hours. So we're taking a look at that. And as I had said before, we'd previously looked at MPI numbers used on claims for submitting for Medicaid services. An MPI number is a unique 10-digit identification number issued to healthcare providers in the United States by the Centers for Medicare and Medicaid, otherwise known as CMS. It is noted on the MPI registry that, quote, issuance of an MPI does not ensure or validate that the healthcare provider is licensed or credentialed, end quote. So basically CMS will give anybody an MPI number. That's what it boils down to. Appreciate everybody's time. Be more than happy to stand for questions.
Committee, we have a few minutes for questions. Do you have questions? Representative Bryce.
Thank you, Madam Chair. Thank you, Mr. Anderson. I appreciate that very much. You presented well, it's obvious that what you're doing is uncovering some of the things that need to be addressed in these programs. I'm a little bit confused when I try to find out, okay, we've uncovered, we've named things, where does it go from there? I know some of them you refer for criminal prosecution on certain cases. Some of them refer back perhaps to KDHE. How do we, for instance, the $22 million a year MCO fee-for-service problem, the invalid NPIs, impossible hours, lack of routine background checks, how do we, what's the action item or what's being done, or how can we as a legislature be sure these problems are not just being identified, but they're actually being taken care of? Thank you.
Sure. No, I appreciate the question. Certainly, like on some of the recommendations and the findings, as we talked about in a previous testimony from the Coach Committee, having tracking for those in this very committee would be a positive step. We always report the responses from the auditee in our reports and allow for tracking. And I think we're going to plan on doing better follow-up on that and monitoring that. The matters that get referred for prosecution have to go through the process of criminal activity. As we all know, the wheels of justice sometimes turn a little slow, but we will be tracking that. Our annual report captures some of that, and I intend to do a better job of tracking these type of issues in our annual report. Rather than just putting raw numbers, we want to have pending issues in there. So that's one of the ways to do it. And it's also through working with KDHE and other and KDADs and other auditees about tracking these issues. And one of our plans is to do follow-up audits on issues that we've recommended in the past and checking those so we can report back on those findings.
And if you could send a copy of your report that's coming out to my staff, we would be happy to send that out to the
Already
committee.
plan to do that.
Representative Ballard.
Thank you, Madam Chair. I have two. I want to just get more information on that list that you say people who are ineligible to be on that list. Is that what you said, that they don't turn it in a timely manner? You said something about the checklist.
Not sure exactly what you're talking about, Representative Ballard. Were you talking about the people who didn't have checks for, whether they're on the exclusion list? Okay. Yeah, they simply didn't do the checks. It wasn't a matter of not doing them timely, they just simply didn't do them. They're required to do them. When we asked for their records of doing the checks from the schools, there was no check done at all. We couldn't find in their records where they'd performed the
They
check.
all have information about what they're supposed to do, and are they supposed to turn that in monthly or annually, what?
The check is supposed to be done upon hiring, and it's supposed to be in the employee's file. And once they do it, then they don't do it again. We requested the records as part of our audit, and the records showed that they hadn't done them at all.
Okay. And I'll follow up on the billing of more than 168 hours. Who are the people that you're referring to, they are billing?
These are the providers and these are in the mental health industry, and they're billing the MCO for these hours for Medicaid beneficiaries. And the MCOs, the reason the MCOs didn't catch it is because these providers are smart enough that they broke it out across the 3 MCOs. So if MCO 1 looked at it, they would see some hours, but it didn't seem outrageous.
Answered my next question.
But because we were able to see the whole universe, we were able to put it all together and said, oh, that adds up to way more hours than it's possible. So that's one of the benefits of having our office, because we can see everything, whereas MCOs can only see their silo.
And what did you do about that?
We're working on that. We're planning on working criminal investigations involving that.
And a quick last question from Representative Carpenter.
Thank you, Madam Chair. Sorry to piggyback on what Representative Bryce was talking about. So do you have all the tools in your toolbox that you need to identify these kind of things? And do we need to do more as a legislature to enumerate these things so that they're followed through on? That's what I'm concerned. We're set here, we can kick the can down the road. We meet in 3 months. I'm not going to remember what you told me you were going to do. Do we need more tools to make sure that that happens?
I appreciate that. One of the things was help of us getting additional staff, because it's all about personnel. We are a very small office. We're currently 10 people. We did get a staffing increase, which is going to help us immeasurably. We're trying to get better software for tracking our cases and what have you. I think having groups like the COSH committee that are tracking issues and going to have good follow-up on that will be assistive. But it's about resources and having time.
Senator Erickson, do you want to follow up with COSH?
Thank you, Madam Chair. And yes, the Government Efficiency Committee has had Inspector General Anderson several times in front of our committee, and we're shocked to find out that basically his hands were tied with making recommendations. And so rest assured, the Government Efficiency Committee does have a plan for acting on the fraud, waste, and abuse that he is finding. So there is that in place now. Thank you, Madam Chair.
Thank you so much. Committee, we're going to next on our agenda, and welcome to the mic, Secretary Stanek. Welcome to committee.
Thank you. Good morning. I'm going to be presenting on behalf of KDHE today. Christine is on vacation. I do have our Director of Operations here, Yvonne Case, who will help me with any items. The slides are pretty voluminous, so I'm going to high level. If I go too fast, stop me, and I'll go into detail. So we'll start with KanCare update. Healthy Blue, not much to report there. We are in basically normal implementation status with daily monitoring, and we've gone from that to steady state status. We're 1 month earlier than we had planned, so there are no outstanding issues there, and we'll continue to meet with them as needed. On page 4, slide 4, there are a number of data points there. related to the number of claims that have been processed by Healthy Blue, how much money that was, how many pharmacy claims, et cetera, just to give you an idea. Our call center metrics are pretty much outlined there related to abandonment rate of calls, which is very low. Most common call reasons, benefits, ID cards, and related to the change or finding of a primary care physician. And for the provider calls, it's benefits, new authorizations or authorization status and eligibility. So kind of business as usual. We do have some service level agreements. We refer to them as SLAs in the Medicaid program. KDHE and the MCOs are engaged in processes to ensure that basically KDHE and the Department of Disability and Aging Services and the MCOs are aligned on the definition of what those are, so what our expectations are for their performance. Those are monitored. We've put a lot of resources and time in developing a more strong program for that. We will begin monitoring each MCO's performance monthly and applying liquidated damages where we need to. We have done this over the years, but we are tightening up that process. We will note that SLA monitoring is one step in the increased oversight and monitoring program, and as you know, the federal government has required us to outline more specifically what we're doing for monitoring MCO performance in any state. We have some performance measures outlined there for KanCare 3.0, pay for performance withholds. The HEDIS is Healthcare Effectiveness Data and Information Set, and there's a bunch of measures, too many to name, that are collected and monitored. Adult and child core healthcare quality measure sets, et cetera. So you can see there are basically 49 contractually required operational metrics across quality, care coordination, provider performance, network adequacy, finance and data management that will be monitored. So just to summarize what we're looking at. We are doing a better job and are establishing some reports and data set measures to each of those components. And we'll use that data in a better way to drive performance improvements. We also are proud to say we are creating some internal and external dashboards that will be public. This was not only allowing us to monitor, but our stakeholders and you all, so you can see, and they'll be published on the KanCare website. Going along the requested items for this committee, starting on slide 8, we have an update on social determinants of health. Basically, there are requirements in the new contracts for SDOH, or social determinants, basically to establish methods, strategies, and tools used to identify and track the KanCare's members' needs that might not be the common health type of requirements that you might think of. So health screens, health risk assessments, and Z codes, which are a code that's applied to the bill that shows the factors that are influencing health status. And the care coordination staff, or the MCO and care coordinators and other coordination models, are responsible for following up and identifying the SDOH needs and connecting KanCare members to resources. And we are making the social determinants of health resource information available to staff and providers to address those. Many Medicaid members, if you're wondering what those are, and just a reminder, the needs outside of healthcare are housing, food, transportation, childcare, and more. Some of those you hear about sometimes through the value-added benefits that the MCO provides. We are also wanting a more coordinated approach to referring members to resources in their communities, so they know in their community, not just in the state. So those things are outlined in 3.0. They don't cost the Medicaid program anything, and they're related to coordination and referral and not payment for those services. There was also a request for a maternal infant roadmap. We basically have developed that with both the Medicaid proper program and public health staff in KDHE. It's an opportunity for collective strategy, more holistic approach to infant and maternal outcomes versus a policy by policy approach. We have 3 areas of focus we're working on in that arena: access to care, data utilization, and workforce development. In access to care, we want people to have the ability to obtain their care for prevention, diagnosis, treatment, management of disease, illnesses or disorders, and other health impacting conditions. We need it to be accessible and convenient. Policy areas that we're considering are telehealth, screenings for anxiety and depression, access to support programs like becoming a mom, medical devices for high-risk mothers, and opportunities from what's known as the TMAW model, and that was reported on by Christine at the last meeting. We are one of the 15 states that was granted this 10-year-long grant called Transforming Maternal Health, and we are working on a pilot for that right now. That is a little bit in limbo because of the transition with the presidential level, but we are excited to start it. Data utilization, you can see outlined there. All of the things that we are required to do, but we'll also have better access not only to data collection, but data sharing and access by stakeholders and a crosswalk of data between public health and Medicaid. And I would say with TMA, that is not just going to be the state. That is a number of stakeholders throughout that are working on that grant with us. Workforce development will be focused on enhanced training, skills, performance, and building capacity through infrastructure, identifying those Medicaid provider deserts, as you know, and overall provider deserts, particularly focused on maternal and infant. And we'll review the codes and strategic key rate increases and try to address inefficiencies. So we are really excited about that, and we'll keep you posted as we go on. On Children's Health Insurance Program, CHIP, just an overview of that, provides health care coverage for low-income children up to age 19 living in families with incomes that exceed the Medicaid limits. By federal law, just a reminder, once a CHIP member reaches 18, CHIP coverage ends, except when the CHIP youth is pregnant or in a 12-month postpartum period. They qualify for CHIP when household income exceeds the limit for Medicaid and other general eligibility criteria are met. It's prospective and not backdated to month of application, as is done with Medicaid. It was implemented, CHIP was, in 1999, and it was directed that CHIP would be a Medicaid lookalike program with the same benefits and the same provider networks. CHIP does not cover HCBS waivers. Those are unique to Medicaid only. State law requires CHIP children to be capitated in managed care to control costs, and capitation payments to the MCOs are the lowest paid amount because these are healthy children. Per federal requirements, children are first screened for Medicaid eligibility. If the child does not qualify for Medicaid, they are screened for CHIP. I don't know if you want me to read, it goes on and on about the requirements, but I'll stop there unless you have specific questions. I'll just note that they're above 166% of the federal poverty level, and they're required to pay a premium. And then the next slide outlines what those premiums are, how the premium payment works. They cannot be disenrolled during their 12-month eligibility period due to non-payment of a premium. They can be disenrolled at their annual review if they have outstanding premiums. If they're disenrolled for non-payment of premiums and they reapply, delinquent premiums cannot be a condition of eligibility. Without CHIP, families will have children in Medicaid and children without health care coverage because of the stair-step eligibility that Kansas currently has for Medicaid, outlined on the next slide. So an example is a household could have a child under 5 that qualifies for Medicaid, but their older siblings, age 6 or older, could fall into the CHIP income range. If CHIP were eliminated, the younger child will be eligible for coverage, while their older siblings would not be. Now, there is a graph there that goes into very much detail of the federal poverty level ranges that are there and what the premium is for CHIP. And I don't know if you want to spend any time on that, but it'll be there for your reference. There's also on slide 17 a CHIP versus Medicaid income limits graph, and it outlines the household side on the left, and then all of the FPL ranges, the children's age, and you can see the staff that manages CHIP has a lot to do because this is very labor intensive and there's a lot to manage. So, but I won't read any of those unless you want me to. I'll keep going. Is that okay? Okay, great. CHIP capitation rates, they're the lowest again in the Medicaid program because they are generally a healthier population. If they're under 1 year old, the average capitation rate is $650 per member per month. CHIP children aged 1 through 19 have an average rate of $282 per member per month. The average per member per month capitation rate across all populations is $120. Higher need populations like long-term care or home and community-based service range from $6,000 to $800 per member per month, which contributes to the average capitation rate. And again, there are a number of slides that outline the snapshot of Kansas that talks about how many patients we actually have and by range. So there's 61,100 patients in the CHIP program right now. There's 26,916 CHIP families. And you can see how that data is incorporated, what the age range looks like, and there's a breakdown by beneficiary count, poverty level, et cetera.
Madam Secretary, we have a quick question.
Okay.
Thank you so much. On the previous slide, I
Uh-huh.
believe you said the total average per member was 120. The slide says 1,200. I'm just wanting to make sure.
Yes, I'm wrong. Thank you for correcting me. Yes.
I just want to make sure I know that
You read it right. Yeah, it's me.
1,200.
Yes, it's
Okay.
1,200. I apologize.
Thank
Thank
you.
you. Please continue.
Okay, sorry. All right. And then on page 21, in 2024, the paid capitation, just to give you an idea what the federal portion is, 126 million, SGF 47 million, and total CHIP for state of Kansas is 173,895,532 million. I'm going to move on to program improvements now. We did a lot of program improvements simultaneous with the KanCare 3.0 negotiation, so I'm proud of the staff for that. We were very successful in our focus on that implementation, and I'd also note the Aetna transition, and we want to thank Aetna for being a good partner there as they transitioned out of the market. It went pretty seamlessly, and they've been very cooperative. It was done by the same staff, as I noted. There was limited time to identify and prioritize program improvements with limited time and new Medicaid leadership. We have done a reorg of the Medicaid program. It's still ongoing, and it's going very well. We've developed an automation roadmap, and that'll be in future slides. We created a data bureau. I talked a little bit about data and transparency earlier and our efforts there, and that's going well. And we're going to use data to make decisions. We're more focused on using data and having some rationale behind our decisions than in the past. We have a new MCO oversight process to ensure better accountability for the MCO performance and goal to ensure better experience. And now with 3.0, transition to a steady state, the focus will turn to program improvements. We no longer have to worry about implementation. Program integrity, a little bit of what the IG spoke of, is an umbrella term that includes payment integrity, internal controls, fraud risk management, and improper payments prevention. We have identified some key areas to improve related to program integrity. One is automated process improvements identified by the Inspector General. So whoever asks the question, whatever happens to this stuff, we work very closely with the Inspector General, and we try to follow up. And one of them has to do about identifying those automated processes for out-of-state or date of death, so patients don't continue to get benefits when they're no longer with us. Current processes are manual and can only be done as workload permits, and like everyone else, everyone is short-staffed for the things like this that count. Not automation's less efficient. The new Data Bureau is also working on creating data sets to analyze the program for improper billing. So if we have improper billing, we want to put a process in place, put system edits in place that are automated, and other strategies. We have a newly defined utilization management oversight that will allow Medicaid to identify deficiencies in controls and documentation, which is very key, and joint meetings with the Inspector General, the MCOs, and Medicaid staff to identify other key areas of focus. And again, that's a good collaboration. We related to efficiencies, we developed a roadmap for improving error rates to decrease full-time employee time and ultimately save money. We're working with other Medicaid programs who have already implemented automation to garner lessons and not reinvent the wheel and implement maybe what they've done to impact our program. It will then allow us to prioritize initiatives, and there might be dollars needed initially to implement some of these things, but and that would be next session, so don't worry. But we will do as we can with the existing dollars we get. And then we have a very strong, I'd say the strongest since I've been here, going on my 4th year, the clinical and policy teams. They're reviewing current policies to identify inefficiencies in policies that some of our policies create. For example, requiring prior auth on items that cost less than $200 or are areas of limited fraud and liability issues. And so that's just a process, a checkbox. Medicaid schedules a meeting with the MCOs to begin discussing these programs where the opportunities are to improve efficiencies and cost savings. We're working with a public consulting group, PCG. They've been a firm that's been within the state consulting on a pilot project to identify opportunities for Medicaid concurrent enrollment detection to occur in spring of '25. PCG, the group, has access to verified coverage information for every Medicaid managed care plan in the United States so that it can instantly identify when an applicant or a current member of Kansas Medicaid is also enrolled in a Medicaid managed care plan in another state, for example. This pilot's free to the state, which is great, and will encompass running 10,000 adults, KanCare members, through the process. If the cost savings will be evaluated when results are compiled, and an additional 1,000 foster care children will also be run as an interagency efficiency to identify foster care members across states as well. We've also increased our proactive communications. There's a number of things there. It might not sound like much, but I will say that communication's key, outreach is key. There's a number of data points there you can read, and the number of worker hours saved by being proactive and not letting this life go on in the operational world. I like to thank the operations team for their work, but those are little things that take a very detailed operations management person to do and monitor, and we're very proud of that work, and it's ongoing. We also have some work going on with missing Social Security number reviews, for example. 511 reviews that could have been pre-populated were able to be completed passively due to the updated Social Security number. All the time saved for things like that. There's also some efficiencies outlined there. I won't go in detail about communications, unassigned medical reviews, unsigned medical reviews and the outcome there, and how many hours are saved, and how that benefits not just the patients, but the state. You can see on page 29, there's a graphic that shows the proactive communications, the application reviews, and unsigned medical review outcomes, and how the improvements have been made. There's some data points on a graph, just to give you a different visual. The bot, which is a computerized agent, is another efficiency. We have case linking and delinking by bot. When consumers have a case in the system for Medicaid or SNAP or TANF and want to engage online instead of by paper or phone, I'm sure you've all experienced this with somebody that you deal with. They say, can I help you? This head pops up in the corner. They create an online account. A request can be linked to their case. The bot takes in those requests. In certain scenarios where it can validate that the request matches the case, and it links them so they can start managing their case online. We hope to do more of this. You can see the numbers there. There's no backlog of case linking requests, and 53% of cases with an active or pending program have a linked account. Related to eligibility, an application status update and call center metrics, there are a number of slides that outline there's currently 8,668 total applications in-house. How many are over 45 days? We do very well there, by the way. We stay under the requirement most of the time, if not all. I've seen one bump up. And then the applications that are in over 45 days in pending status and what they're waiting for. And you can see the breakdown by elderly and disabled, long-term care, family medical, and registration. The call center metrics are there for your update on the next page. Again, our average speed to answer is pretty excellent. Our abandon rate is also very good. I'd like to talk about the request for programs that KDHE is involved in related to aging adults. Medicaid doesn't totally include programs for aging adults.
Madam Secretary, if I may, before you go into the aging portion, let's just see if there are any questions, because the majority of this was regarding children and families, before we go to the aging, if that's all right with you.
No problem.
Committee, do we have questions over the first? Yes, Senator Virgil Peck.
Thank you, Madam Chairman. I've got several questions on things that have been mentioned. Just the most recent, the Public Consulting Group, what's that cost KDHE to pay a consulting group? Or is there a
That
cost?
study that I'm referring is free to the state.
So the public consulting group is a government entity?
No, they are like a Deloitte, Accenture. They're an outside consulting group that we use in the state. Different, I think KDADS uses them as well, but KDHE uses them, and they have offered to do this one for free. I would have to get you what we pay them for the work that they do for us. They've always been part of the Medicaid program, though.
And you showed a slide as it relates to the calls, and January 25 didn't look so good to me. The call drop was nearly 20%, and the time wait was significant. Do
you
you
on
have an
call
answer
center
why that
metrics?
1 month looks so bad?
I believe that would be related to the enrollment. Yvonne, I'm going to ask Yvonne to help me out with that.
Hi, Yvonne Case, Director of Operations for Medicaid. Senator Gossage and Senator Peck. They had a 3-day outage related to a system problem our contractor did. They recovered right away. They made callbacks, but that's what happened in January.
That's fine. I just wanted to find out what the answer is, because when you compare January 25 to the other months, it doesn't look good at all. Thank you.
No, it doesn't. But again, they had a quick recovery. Thank you.
I have one more question, Madam Chairman. As it relates to the Children's Health Insurance Program, I heard you say, and I'm sorry, Representative Bryce and I were seeing who could read the screen across the room, and he's much older than I am, so he was struggling. But in any event,
I'm struggling.
as it relates to the CHIP program, I heard you say that a child cannot be removed during a 9-month period because of non-payment. I'm sorry, a 12-month period.
Right.
Do we go back and require back premium payments?
No, I didn't. I saw that it said no. I read that it said, let me find that. I apologize. Let me find that slide. If a child is disenrolled for non-payment of premiums and reapplies, delinquent premiums cannot be a condition of eligibility. So no.
It looks like to me this system could be easily gamed. I pay 1 month premium at the beginning of the 12-month period, don't pay anything for 11 months, and then re-enroll and pay 1 month. Is this a federal or state requirement that we cannot go back and collect, or can we just don't?
I believe it's federal. It's federal, but I will go back. I don't believe we can do it. CHIP has very stringent federal requirements, but can I have that as a follow-up and get back to the committee? Okay, good question.
I appreciate that, because again, as an insurance agent, I can see how I would easily game this.
Okay, let us find out.
Anyway, okay, thank you, Madam Chairman. I'm not going to ask you more on at this.
Okay, okay, thank you.
Senator Petty.
Thank you, Madam Chair, and thanks, Secretary, for being here. I have a couple of questions. One, you mentioned, I have to read my own notes. So it came up with the Inspector General about students and MCOs and that paying for the care in schools. Or
Yes.
the school. So could you speak to that?
I can speak, and the IG still here? Yes, so we just met with the IG to talk about this. The school-based services program is complicated, and the audit revealed many things that KDHE agreed with. I would say high level, it's going to take, my guess, years to get a program that is fully meeting all of the requirements that we can manage it. Back to staffing, this was not a program that was able to be well-staffed and overseen, and also it doesn't just involve KDHE, it involves the schools. And this is a long-standing issue where we need to do a better job on training people, making sure that the schools know how to bill appropriately, et cetera. The report's very good. We had a collaborative discussion on it recently, and we have a road forward, a path forward to add staff, 3 staff, actually, to manage this. I can't speak to how the billing ended up in the position that it did related to what the Inspector General had noted, but I would say training is part of that And we need to do a better job working with both the MCOs and the schools.
Thanks for that answer. And then you mentioned about better signage for the I think on the dock sheets. And I was just curious as to whether that was an issue of moving the signage page to the front like you did with the Medicaid review.
My operations director's here with me, and we would have to look into that. We're not totally sure on that one.
Okay, then I wondered about, since we're talking about CHIP and with kids, I wondered about this sedation dentistry issue. Has that been addressed in any way?
We don't have staff here to answer that, but we'll look into it. I don't remember that being discussed recently related to the CHIP program, Senator, but I'll get an answer on that.
And lastly, you said that with CHIP, this is a change, is that we're at 166% of federal poverty level?
Yes. Above 160, those on CHIP above 166 are required to pay the premium.
Oh, okay, or required.
Are required to pay the premium, yes, if they're above the 166%.
But children above 166% are eligible for CHIP. They're just
Yes.
Okay.
Yes, and I don't know if you have the slides, but there's a whole outline of what they pay per premium depending. For example, they pay $50 per family if the poverty level is 219 to 255%. And there's a whole list of those outlined on the slides. And if you don't have that, we can get it to you.
No, I can see the slides that are
Okay,
being
all right.
provided for us. So thanks for the answers. I appreciate it.
Thank you.
Senator Erickson.
Thank you, Madam Chair. Thanks again for being here.
Uh-huh.
Going back to Senator Peck's question on continuous eligibility, if a child is on CHIP, is the parent or caretaker automatically receiving coverage as well?
No.
No, okay. And is it possible to get a list of the value-added benefits of the current MCO
Yes.
contract compared to the KanCare 2.0 and the cost of those value-added benefits?
Yes.
Okay.
We, actually, there's a lot of interest in those since that came out a year and a half, 2 years ago. And so we've been keeping up more on that. Yes, we'll get that to you.
Thank you. Thank you, Madam Chair.
And just for the members, they're all published on the MCO websites as well, just for what it's worth.
Thank you, Madam Secretary. On slide 21, I see that all funds was 173, almost 174 million for the CHIP program for typically healthy kids. I would like to have a list of a total number of claims that were paid out for these children and then the amount of the claims that were paid so that we could compare that to the amount that was paid in the capitation.
Okay, we'll have to get that for you, but we will do that.
Thank you. Committee, additional questions? Yes, Representative Carpenter.
Thank you, Madam Chair. So, Madam Secretary, we'll have our first consensus estimates here just shortly. So can you get out to the committee the difference between last year's 2.0, the difference between the cost of each of the MCO compared to last year?
Each of the cost of their,
The cost of providing services,
okay,
comparing the 2 years.
2 to 3.
Yeah, I've long been concerned we entered into this one without really having a lot of cost estimates. We have 3 months worth of now comparable costs to this program. We will have this spring.
Yeah, we just, and those were all actuarially based. We had a whole cost assessment done. And so, yes, we'll get you the compare. I just want you to know we did that part, but yes, we'll get you that. Yeah.
I certainly get the per member per month and the capitation rate, but I'm looking at trying to compare
Okay.
last year's program versus this year's program.
Sometimes it's hard to answer that, so it might come in different ways that we have to present it, but we understand why you want to look at that. So,
Yes, of course. And one more small question. So I know they have till the end of the year, the MCOs do, but care coordination, is there anything that you can report to us about how that's coming about and what the plans are for care coordination?
The plans are sooner than work on care coordination with the MCOs. I would have to get another presentation that was given to give you the outline of the dates, but they had until the spring to start in earnest working on some of the things that we were doing. So I cannot answer that in detail today, but I will get you something, okay?
Very good. Thank you. Thank you, Madam Chair.
Representative Ballard.
Thank you. Representative Carpenter, his last question was mine, so
Okay.
I'm fine with that. But I'd like to know on the chip, I hope I'm correct. 3 years ago, we talked about it was underutilized. We didn't have percentage of children. What is the percentage of Kansas children on chip?
I know that. I thought that was in here, and I apologize that I don't have it.
One of the reasons I'm asking it, because, during the summer when I was walking door to door and I was talking with a few of the families, they didn't know about CHIP. And one of them especially didn't know is because they newly were bankrupted. They used to have more money coming in. And when I was trying to explain the eligibility and all, and then I called in and someone indicated that we could have more children enrolled, but we don't because parents choose not to enroll them. How would you respond to that?
I know just from my limited time at the State Employee Health Plan, being the director there were patients that they had the option, even within the state employment realm, to go CHIP or otherwise. And I don't remember what the requirements were for that, but it was a choice. And now, yes, and so it wasn't because they didn't know about it. It's actually when you enroll in our state employee health plan, it's outlined the difference between CHIP and just taking the regular health plan, for example. So I know it's publicized, and I also know when people do enroll, that our staff makes sure that people understand the difference between taking CHIP and not. So I will have to get you what we do to educate people, and I'll get you that percentage because we did fail to put on that percentage of what people are, how many CHIP people are in the program.
Well, you just enlightened me on something that I did not know that about the choice.
It's a choice.
So that makes sense to me now. Very good presentation. Thank you.
Okay.
Yes, Representative Bryce.
Thank you, Madam Chair. Thank you, Madam Secretary. I have just a quick question. I'm fascinated with the social determinants of health. That seems to be kind of the future for a lot of what we do. And I know there's no money necessarily spent. It's a referral program. I guess my question is, do you see any roadblocks statutorily or otherwise from using faith-based organizations, referring to faith-based organizations? I know a lot of times there's a barrier between state government maybe and faith-based organizations and vice versa. But do you know of any hindrances from referring to faith-based organizations for these social determinants of health issues? Thank you.
I do not know any restrictions. I guess it would depend on what it is and if there's money exchanged or something, but no, I think that, as you know, there's many organizations, faith and non-faith, that provide services that are in that social determinants of health category, so.
It seems like it would be a good fit for me. I just wondered if there were any hindrances.
Not to my knowledge, no.
Thank you very much.
Representative Sutton.
Thank you, Madam Chair. I'm looking at the numbers here and looking at the CHIP expenditures and the total number of children enrolled in the program. And I'm coming up with almost $3,000 a month per child, or I'm sorry, $3,000 a year, sorry, per child. Yeah, that would be excessive. And this is the healthy population. So I'm wondering, that number just seems high to me, having raised children that were healthy. Those expenditures, $3,000 a year seems excessive. What kind of
Well,
What's in that bucket that I'm not seeing?
the average number is 1,200, just for what it's worth. I don't know what you're eyeballing, but the average on slide 19, the average per member per month capitation across all populations is 1,200. The higher populations, long-term care and community-based services, are 6,000 to 8,000 per member per month.
Specifically at CHIP.
I'm looking at the CHIP expenditure slide also. I will get you that, what's included in that. I believe it would just be normal doctor visits, hospitalizations, ER visits, whatever, but I don't want to speak out of turn, so let me get you that, okay?
Right, yeah, I was looking, just so that you know what I'm looking at. I was looking at the CHIP total, 174 million, dividing that by the 61,000 that are involved.
I see.
Real quick math there, but it came out with a number that I found a little bit surprising.
Okay, all right, let's find that out, and that'll be on our follow-up.
Excellent. Thank you, Madam Chair.
I'm sorry you don't have the CHIP expert here today. I'm doing my best, so.
Senator Petty.
Madam Chair, thank you. Actually, Representative Ballard asked the question, so that's why I took my hand down.
So just doing some quick math, following up on what Representative Sutton was asking. It shows on slide 19, 650 per member per month, times 12 would be about 7,800 in capitation per year.
Younger than 1 year old, right?
Correct. And 282 per member per month
For 1 to 9, yes.
1 to 19.
Yeah, now these are the numbers that obviously the team put together and what the data shows, but if there's something more we can get, and I'm hearing some more specifics, and I think we can do a good explanation to you about what that entails and so forth. Like the Medicaid program in general, many idiosyncrasies.
Totally aware.
And the roadmaps you can go on,
So,
but anyways.
Right, it's just good when we're watching the dollars.
Yeah, I
Which is
agree.
why I ask for the total number of claims and then the amount of those claims that were paid for that population.
We'll get them.
Okay, committee, other questions regarding this portion of the presentation? Seeing none, please proceed with the aging portion.
Okay, I'm going to talk about aging. Aging adults is a big deal and has hit the roadmap for healthcare. Medicaid doesn't include programs for aging adults. Several programs do exist within for KDHE. We do have the Division of Public Health, and we work with community health partners in implementing many of those. Some of the programs that we work on for aging adults include chronic disease prevention and management, diabetes, cardiovascular disease, blood pressure, tobacco cessation, healthy eating, and we are part of the Kansas Seniors Market nutrition program. You see in the summer we have that farmers market out here as part of that. Fall prevention, stepping on, is one of the programs. Matter of balance is another one. We have community clinical linkages, intergenerational childcare. You've heard about these facilities that have both a nursing home and a childcare facility. And KDHE also serves on several committees for aging adults. A national initiative this year you might have heard that's being facilitated by KHI, Kansas Health Institute, is called the Age-Friendly Kansas Steering Committee. It's a strategic partners between state agencies, again led by KHI. It is all about things like how do you keep people in rural Kansas in their home when there's no nursing home, but the aging person wants to stay there? And what are their needs for food, nutrition, transportation, all of the kind of the social determinants we just talked about. We're also a member of the Multi-Sector Plan on Aging State Coalition, and we also have the Alzheimer's and Related Dementias Coalition that KDHE works on. So you're on the other side of KDHE Public Health, but it all flows over. FMAP changes each year. This was an add-on because we've had some late breaking news with the federal government, and we're watching obviously how they might impact the Medicaid program going forward. Every year, FMAP is calculated for each state. That's the federal share that we get via an established methodology in the federal statutes. It generally compares Kansas's per capita income to the national per capita income. In 2019 and 20, prior to the health emergency, FMAP was increased 57.10, and it was 59.16%. The current FMAP rate for the federal year 2025 is 61.87 for Medicaid and 73.31 for CHIP. The final FMAP rate that's been calculated for 2026 is reduced slightly to 60.67% for Medicaid and 72.47 for CHIP. I don't have what that amount is, but I can say, oh yes, I do have it, sorry. So the final rate is already contained in caseloads estimates. Preliminary rate for federal year 27 would reduce it even further to 59.93 and 71.95 for CHIP. So you can see now we're off the federal health emergency, but plus there's recalculations going on. So bottom line is our federal match dollar is the federal amount contribution model from the state is being manipulated to show a lower rate. The final 27 rate won't be finalized until September of this year. The impact estimated is $23.49 million for state general funds, and for Title 19, it is $1.663231 for CHIP. This impact could fluctuate based on current estimates for the state fiscal year, depending on what the caseloads are. So a message here today is to throw these numbers at you, but also just to say, we're watching it because we're going to have more that we're going to have to pay out of SGF if the federal government keeps reducing this amount. The rest is just a bunch of the written-only updates on the different performance of the MCOs, where our patients are and all of that stuff. Unless somebody wants to go through any of those, I would leave it at that. So any other questions for me?
And I would say, just to clarify, before the public emergency, they kept people on, they raised the FMAP. If you kept people on, the anticipation was, of course, that the FMAP would be reduced.
Yes, it was.
Once the emergency was completed.
It was.
Any questions, any additional questions, committee? Okay, Representative Ruiz is online.
Okay. Hello.
Thank you, Madam Chair. Sorry, but I'm tired. So I'm home. Regarding slide number 34 for the aging adults, it's been very concerning to me and many other people that we don't have a committee that is devoted to senior. Just looking at our senior population in the state, and it was taken away, and we've not had that committee for a while now. Do you think there's been any impact at all, negative impact from the lack of the legislature having a committee focused on aging and how our aging population, all the issues related to our aging population?
I might defer to Secretary Howard from her arena, but I would say when the age-friendly initiative came out, that nationwide, and we were all brought into it, and we're brought into that with many others. It's not state-specific. It's the state of Kansas specific, but it's not the state. Being part of that, I think, is a great collaborative. I can't really answer your question. I have not been here long enough to know when that committee was in place. I don't know. I would like to ask, if you don't mind, I'll have Secretary Howard answer because.
Secretary, if you want to wait till because we're almost to you.
Okay, all right. I just
That's
thought
okay,
it would be more
Representative
appropriate.
Ruiz, when
Yes, that's fine.
Okay.
Thank you, Madam Chair.
Secretary Howard will address that.
Okay, great.
Okay.
Thank you.
Additional questions, committee? Yes. Senator Peck. And Senator Petty, you're in line.
Thank you, Madam Chairman. You gave us some expensive numbers as it relates to the federal government changing the percentages on Medicaid. Are they also looking, does this include changes in the percentage for when the expanded income eligibility for Medicaid? Right now, my understanding is it's 90-10 for the expanded Medicaid.
Oh, you mean for expansion states?
Well, if we were, or for other states that have, because we have not, but you gave us some numbers that show we're going to, as a state, probably have significant additional expenses. If we were an expansion state, are those percentages being looked at and changed?
I can't answer that right now because this is new information that we just received, and because I think we've only been focused on us, I don't know what the national look or take is on expansion states and FMAP, so let me find that answer out and get you that answer, okay?
I would be interested to know if the percentages are changing
For them as well.
that demographic as
Yes,
well.
I will look into that.
Thank you, Madam Chairman.
Senator Petty.
Thank you, Madam Chair. And my question was actually about the FMAP as well. So I just wanted to be sure I understood this because another question had been asked. This is an FMAP change that has nothing to do with the FMAP increase that we had following COVID. Would that be correct?
Well, it's coming off of that. It's part of it, but then it's also part of their new calculation. We get a calculation every year, as you know. But yes, the end of the public health emergency does impact that.
Okay, so we had a change with the end of the public health emergency, and this is another change. Is this correct or not?
Yes, yes.
Okay, another change. Thank you.
And if I may, this is because there was a slight reduction each year. It wasn't an immediate.
Right.
This was a stair step down.
Yeah, and we had a slide on that at one meeting that showed the 5-year outlook.
Representative Ballard.
I probably should just wait, but I don't want to forget it. That question that Representative Luis asked about the departments, I'd be very interested in that because I was here when it was a separate department of aging before we combined it. And
okay.
I'll wait to hear the response to make my response because I have in many ways seen a big difference between when it was just Department of Aging to when we combined it with it. And I always think anytime you put 2 or 3 things together, something is going to go missing.
Okay.
Okay. Thank you, Mr. Chair.
Okay, committee seeing no other questions. I do want the committee to know that in the early part of May, I will be meeting with CMS on about Kansas and some of our concerns. So if you have any of those, you'd like to get that to me, as well as the department. And now we'll welcome Secretary Howard.
Thank you, Madam Chair. Laura Howard, Secretary for Kansas Department for Aging and Disability Services. Thank you for the chance to be here today and to speak with you for a little bit. I will kick off this presentation, and I have a number of colleagues doing some of the pieces. I want to do just a couple of quick overview pieces. The first really just relates to some things coming out of the past session, and that also calls out maybe some things that this committee may wish to monitor as you go through the rest of this year. We were very pleased, maybe starting with where we left off on aging, we were very pleased to see some additional funding for senior nutrition, $2 million that offset some cuts at the federal level and helped fill some gaps here. Also, we were very pleased to get the additional slots for the community support waiver, also in the IDD world. I would suggest that this committee monitor, we had in our budget requests for funding to avert the need to start waiting lists on the frail elderly, technology assistance, and brain injury waivers. As we talked during the session, our projections showed that we were going to outpace the capacity on the waivers, and we did not receive funding for those, so we would certainly want to be reporting back to you. There will be some technical pieces we will need to do federally to get authority to start waiting lists should we need to do so, but that will, I think, be an important piece for us to be reporting to you on a quarterly basis in terms of any need to begin waiting lists on those. We were pleased to see the proviso related to contract staffing at Larned in fiscal year 27 was removed, kind of late breaking news. We appreciated that, although we did not receive any funding for that staffing for fiscal year 26 at Larned or Osawatomie. So you will see some, probably some supplemental requests from us next year as we continue to work hard to reduce that reliance on contract staffing. And we appreciate the way the legislature has helped us with additional tools, like some of the bonus authorities, that is having an impact. It just isn't having as quick of an impact as I think we would all like to see. The other piece I wanted to speak about just briefly was just some federal updates in terms of things happening at the federal level that are impacting us at KDADS. You've heard a lot, I think, in the media about, lots of different things about various federal funds and federal grants. The one impact that we have had thus far at KDADS has been some grant cancellations from the Substance Abuse and Mental Health Services Administration a few weeks ago that related to some COVID ARPA grants from the mental health and substance use block grants. Those are grants that would have lasted a few more months. Those were grants that we had awarded to about 45 providers across the state. And the federal action pulled back about $7.5 million in that funding. Wider range of impacts. I mean, there was funding to prevention coalitions across the state, some direct impacts on substance use treatment, some grants we had related to housing and homelessness. It was a wide array of grants, as I said, impacted about 45 providers. We are in the process of submitting an appeal. I mean, I don't think that will be successful. SAMHSA does have an appeal process related to that. So again, I just wanted to let this committee know, thus far, that's really the only kind of financial impact we have seen federally at this point in time. I did want to mention as well, there's a large reorganization going on at the U.S. Department of Health and Human Services, and that's led to, some challenges in communication. So many staff have been reduced within HHS in the last few weeks. So sometimes that just means that the program manager that someone has talked to is no longer there. So we're having some delays, in getting responses and answers. And a lot of regular meetings and scheduled things just aren't happening right now. I mean, they'll get those rescheduled at some point in the future, but some of those things are not happening. More relevant, I think, to SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Administration for Community Living, where the aging programs resides, is that those two entities will kind of cease to exist as separate operating divisions of HHS in the future, and they will be rolled into a new operating division that's going to be called the Administration for a Healthy America. And so a lot of uncertainty just in terms of what that organization looks like. I've been through a lot of reorganizations myself at the state level. So again, we're just in a little bit of that transition period in terms of what that might look like and where programs might operate. So again, just some uncertainties there that I just wanted to let you all know that we're tracking and continue to try to communicate with our federal partners. But sometimes we're having significant delays just in being able to get answers right now, just during the transition period. So we'll keep you posted if we see impacts. As I said, that new administration will have SAMHSA, the Administration for Community Living. We'll have HRSA, kind of that has responsibilities over some of the public health workforce, the federal qualified health centers, as well as some smaller entities in that new administration for a healthy America. So again, there's been some staffing reductions at regional office and consolidations of regions. The Kansas City regional office stays in place. There were 5 out of 10 regional offices that were eliminated. Kansas City was not one of those. So again, we're not exactly sure what their scope or span will be, but again, just a little bit of impact there. We're looking closely, as at the congressional level. I think the next impacts that we'll see will be as congressionally as the budget gets sorted out. And I think we'll obviously be talking with all of you in the future as we see what those impacts might be. So I wanted to mention that. In terms of the questions on aging that just came up, it was very helpful to us. It's been a short time since it's only been a short time since there hasn't been kind of a senior focused committee, but there was a senior task force, and then there was Children and Seniors Committee on the House side. I mean, one thing I would say from the senior task force, and that included legislative and public members, there was a really great roadmap that got developed, and that's just a few years ago. That's been a great framework for us as an agency. I appreciated having that focus, but I kind of feel like it's been a little bit too short of time to know what the impact has been of maybe not having a specialized committee. We certainly know we have the public health and welfare committees. We do a lot through the budget process, honestly, in terms of talking about aging issues. In terms of focus on aging, about a year ago, I decided to recreate within KDADS a separate commission on aging. I've kind of felt like it was merged with all of the disability services and the HCBS programs, and I kind of felt like aging programs were not getting the attention that they needed, the services through our AAAs, and so we created that separate commission. You'll actually have the chance to hear from Commissioner Anderson today. And we're really trying to redevelop some things that used to exist in the state, like the Advisory Commission on Aging. We're getting some final appointments for that and some things like that. So again, we're trying to put more of a focus on that as an agency, just so you know that. Madam Chair, I was also going to cover, we don't have Deputy Secretary Bruner with us today. I was also going to cover just the state hospital, the South Central Regional Hospital piece before I finish my part. So just an update on the South Central Regional Mental Health Hospital. The preliminary construction permit was issued in January. Construction started in February. We expect to be completed by October of 26. We've made the first payments for the construction. We appreciate the legislature moving forward with the bill that actually ended up ultimately in House Bill 2249 and is now law that creates the facility in statute, designates a catchment area, and authorizes the admission on the forensic side of criminal defendants. So just as a reminder, this will be a 104-bed hospital. Split between psychiatric admissions and forensic admissions on the two sides. We've got a couple of pages of photographs that just kind of show, Scott was really excited to show that ground is being dug. And we actually were really excited last week, the day before the veto session, to have a formal groundbreaking. And I think Senator Owens is online, and I think he was able to make that groundbreaking. And that was really exciting to just celebrate that, especially with some of the local officials who've been such great partners. This has been such a neat project in the sense that, the Sedgwick County really championed this, and they really have managed, we got ARPA funding for this to support part of it, and they really managed sort of the whole execution of the RFP and construction process. It will be a state hospital. It will belong to us. We had ultimate decision-making responsibility, but they really managed that process. It was a really unique collaborative that has worked very well. So again, I wanted to celebrate that groundbreaking and say that at this time we are well in place of that getting started and to be ready to open in late 26. So that was what I was going to talk about today, Senator, before I turn it over to others. But I'd be happy to stand for any questions the committee might have for me.
Do we have any questions for the Secretary? Representative Carpenter.
Thank you, Madam Chair. So in last year's budget, this year, you lapsed $150 million worth of waiver money. And now we're short in the waivers of what, 10 million, I think it was, the projections were between the brain, all the waivers.
That's correct.
So how did we build up $150 million worth of funds by whatever means, and then we lapsed it, and now we're asking for $10 million arguably. I don't know exact amount, but it was
Sure.
in that range, so.
Yeah, thank you for that question, Representative. You know, a lot of that was really just about process. I mean, it kind of goes back to the conversations you were having a few minutes ago about the enhanced FMAP. An enhanced FMAP that related to the caseload programs, which waivers are not caseload, you know, got adjusted in the caseload process. The funding and the waivers did not get adjusted. And so, I mean, that funding set, but we didn't have the authority to spend that for anything else. And so, you know, the lapse took place, and that's correct, that 100 and some million, I think you're right, I think close to $150 million went back to the general fund, but we didn't have the authority to just reallocate that ourselves. And so we needed to make a separate request when we needed the additional funding. I certainly, you know, felt like in the context of, yes, that was a lot of funding going back, but it was also kind of one-time funding that was kind of sitting there, that was savings to the state. It wasn't going to be, you know, ongoing funding. So again, we didn't have the authority to spend that ourselves, to just reallocate that and say, we're just going to add that to the base of other programs. So.
Representative Ballard.
Thank you, Madam Chair. I just want to follow up on your comments that you made on when we were talking about the aging. And I remember you had those committees before. What I'm not sure of, did I hear you say that's something you may want to bring back or you plan to do maybe in 26?
Yeah, at the agency level, statutorily, there is authority for an advisory commission on aging. That went dormant many years ago. And so we are trying to bring that back. And we actually have, you know, the appointments process through the governor's office in terms of getting appointments for that advisory commission. I think it's important to bring that back. And you should see that active within the next couple months, I would think. Yeah.
Well, I can appreciate that. You know, when we put it with disabilities, it's almost as if you looked at age as a disability, but there's different things with age that creates a disability. So I understood why they did it in many ways, but it took a little bit of what I would call the dignity away from when you say Department of Aging, of the kinds of ways that people see it. Because even among aging, there's probably so many different degrees of their aging and what they need and the diversity of it all, that I think that needs to be discussed, because it's not a one size fits all just because you reach a certain age or because you have, you know, whatever it is. So that would be very helpful.
Yeah, thank you, Representative. That's a bit why we did that and recreated that. And you'll hear a bit more about the aging programs from the commissioner in a few minutes.
Thank you very much. Thank you, Madam Chair.
Representative Ruiz.
Thank you, Madam Chair, and thank you, Secretary, for answering the question about the, you know, the fact that we don't really have a committee devoted to the on aging. I've heard from many constituents in many advocacy groups, organizations that work with folks in the aging arena, and they all miss it, and because it's you know, it's out of sight, out of mind. And when we don't have a committee that is solely focusing, well, or at least even partially focusing on the aging population, they're forgotten. I will continue to ask that we have a committee, that we bring that committee back. There's so many things that we need to do, as you know. And we just, there needs to be more of a legislative focus on aging, in addition to all of the things that you are already doing. But I appreciate everything that you do for us. Thank you, Madam Chair.
Thank you, Madam Secretary.
Thank you. Just in terms of the next part of the presentation with Deputy Secretary Bruner being gone, we have Commissioner Mike Dixon here to talk about the Parsons Behavioral Health Unit, and then we'll be back on the regular agenda.
Very good. Thank you. Welcome, and please introduce yourself for the record.
Good morning. Thank you, Madam Chair. I'm Mike Dixon, State Hospital Commissioner. I'm going to talk a little bit about the Behavior Stabilization Unit at Parsons State Hospital, which is a specialized unit that is going to serve people in crisis across their entire lifespan across the state of Kansas. Individuals admitted to the behavior stabilization unit will be provided with intensive individualized behavioral assessments and interventions, psychotropic medication evaluations, and services from applied behavior analysis and speech language psychologists, pathologists. We've had a really difficult time getting this unit open. We've been really unable to staff it. I am happy to report that as of today, our last staff that's needed is going through new staff orientation, and we should be able to start taking people within the next 2 weeks. It is designed to be short-term, bring people in, get them stabilized, and get them back out. We're looking at an average stay of 4 to 6 months. The unit will have 3 beds on it. We're really fortunate with the talent that we have running the unit. We have 2 board-certified behavior analysts, which is my director and the assistant director. We are asking for additional training for the staff that work there. We're asking them to become registered behavioral technicians, which is, it has some classwork and a 2-week practicum underneath my BCBAs that run the program. The next bullets on the page is really just about what we've done to try to staff the unit, but since we're opening in 2 weeks, I'll skip those. We're real excited about this unit because it is going to provide services for people who just don't have any other options, who are possibly stuck in a emergency room someplace or leaving a PRTF someplace and don't have really a good option to go to. With that, I can stand for questions on the BSU.
Questions, committee? I have one. No, we've heard about a few years back when we closed state hospitals, and now we're opening state hospitals, and the notion was we'd have what, CMHCs who were supposed to pick up the slack. Can you tell me how these 2 are working together and that we're opening these new hospitals, and tell me what I'm missing?
So are you talking about the Wichita Hospital? The goal of the Wichita Hospital is to bring down our waiting lists because most of the individuals that go in there will be court ordered into a facility like that to get competency evaluations or restore competency. So the whole goal of the Wichita Hospital is to bring down those waiting lists. The 3 beds at Parsons is really separate from that. This is for people that are just in crisis and there just is not a place for them to go. I don't know.
I guess I'm just trying to understand, and again, it's not a pejorative comment, it's a question. And I'm trying to, why did we close the hospitals in the first place? And then now, and we thought, well, we had this other option with CMHCs, and it looks like we didn't actually, like that's not really meeting the bill, and we really do need the mental health hospitals. Is that what I'm hearing you say?
I think we need the Wichita Hospital.
Okay. Thank you. Other questions, committee? Seeing none, thank you. And who's up next, Secretary? Please introduce yourself to committee.
Good morning, Madam Chair and members of the committee. My name is Taylor Bremer. I'm the Assistant Behavioral Health Commissioner for the Kansas for Aging and Disability Services. Before diving into the slide, perfect, I want to share our mission and vision to help connect these grants to a bigger picture. So the Behavioral Health Commission mission is ensuring all Kansans can access integrated care services for prevention, treatment, and recovery to live safe, healthy, and successful and self-determined lives in the community of their choice. The vision is to have Kansas communities support services that promote wellness. A roadmap has been set to accomplish this vision, and these grants help us get there outside of state general funds. So today, the committee requested information on what federal opportunities the Behavioral Health Commission has sought out to achieve our department goals. So because we understand the importance of braided funding for programs that have been created to help achieve our mission and vision, KDADS has sought out numerous federal grants over the years, but today I want to highlight a few for you all. I'd like to provide some data before I get into all of this to help provide some context of why we sought out these goals or these grants. So last year during the presentation that Deputy Secretary Brown presented to the House Welfare Reform Committee in February 2024, he stated that the 2023 point in time count for the unhoused was 2,636 individuals. The 2024 point in time count is 2,815. Of the 2023 numbers, 40% of those individuals reported having a disability, 21% reported having a serious mental illness, and 16% reported having a substance use disorder. So since that presentation, KDADS, in collaboration with the Kansas Housing Resource Corporation, secured the 811 Project Rental Assistance Grant through the U.S. Department of the Housing and Urban Development, otherwise known as HUD. So this grant provides funding for projects to build and develop housing and provide rental assistance to Kansans with physical and developmental and behavioral health disabilities to live in a supportive housing environment. So why the 988 grants? Well, according to the Kansas Department of for Health and Environment Suicide Dashboard, between the years of 2011 and 2023, 6,610 suicides occurred. This was statistically significant with a 43.6% increase in the death rate during that time period. But since 2001, the rate of suicide in Kansas has increased 65%. So a bipartisan bill, Senate Bill 19, was signed to fund the statewide suicide prevention line 988. KDAD sought out additional funding to support this initiative and provide funding for providers to build the infrastructure that is so vitally needed to get people connected to resources that they need in their most vulnerable time. So integrated care then helps connect all of these pieces. The Kansas Zero Suicide reported that most people who attempt suicide make some type of health care visit in the weeks or months before they attempt. The goal of integrated care is to streamline services by coordinating that care for those individuals across different specialties and settings. So this type of integration allows to treat the whole person instead of piecemealing services together. With the promoting the integration of primary and behavioral health care grants, funding is given to federally qualified health clinics, rural health clinics, and community mental health centers to help develop the needed infrastructure to have the service model and referral system in place for this. So really this list goes on, but these are just a few of the federal grants that KDADS has sought out over the years and secured to ensure that sustainability of our programs that help Kansans lead healthier lives. So the Behavioral Health Commission will continue to seek out different grants and apply for them and secure that funding to ensure Kansans have access to treatment, prevention, and recovery like our mission and vision state. So thank you for allowing me the opportunity to provide this testimony on behalf of KDADS, and I'll stand for questions when appropriate.
Questions, committee? Thank you.
Thank you.
Welcome to committee.
Good morning, Madam Chair, members of the committee. Thank you for the opportunity to present this morning. My name is David Anderson. I'm the Commissioner for Aging Services at KDADS, and I'm here this morning to talk with you a little bit about non-Medicaid services available for older Kansans. Some slides I'd like to walk through with you, starting on page 13 of the slide deck. Very good. So principally, the Older Americans Act was a piece of legislation passed in 1965, and those are federal dollars passed down to the states to help provide services for older Americans. This includes in-home services, which could be bathing and cleaning, nutrition services, congregate meal sites, home-delivered meals, family caregiver supports. They also run some employment programs. As you're aware, in 1989, the Senior Care Act was passed here in Kansas, and it mirrors many of the same kinds of programs provided by the Older Americans Act, although it is means tested. People have to have a functional assessment and achieve a certain score of functional difficulties, and it is also tested on their income. These sources of funding come to KDEDS and then are passed through to our community partners and administered by the area agencies on aging. The goals of these programs are to help older Kansans age in place. In terms of nutrition, just a little information, 17,000 older Kansans took congregate meals, and over 13,000 had home-delivered meals. The total for the meals provided was about 3.3 million meals. It's important also to know, in terms of home-delivered meals, that oftentimes that may be the only contact a person has during the day. I believe Representative Ballard and Ruiz spoke to sometimes older Kansans become kind of invisible, and that's really true with those folks who get home-delivered meals. And so having that contact, and in fact, most of the home delivery services have plans as to what they need to do if the person doesn't respond when they show up to give them their meal. They have phone numbers they call to make sure family members are aware and somebody can intervene appropriately. Next slide, please. We also administer federal Medicare programs, the biggest of which is SHIC. That is the Kansas version of SHIP, Senior Health Insurance Counseling for Kansans. So when people turn 65 and want to go and find out about Medicare, SHIC counselors are volunteers affiliated with the AAAs, and they're trained to provide unbiased information and help people make those decisions. I've had several instances where people have talked to me about how difficult that process of understanding Medicare and those choices are, and I always make the same recommendation. I tell them, you know, you should call your local AAA and they can help you with this process. Successful businessmen. In fact, I listened to a podcast coming to Topeka yesterday where a Nobel Prize winner in economics, professor at the University of Chicago, talked about how difficult he found the decision to which of the products Medicare had he should choose. And so that further, in my mind, indicates the importance of having these programs. SMP, Senior Medicare Patrol, is designed to help people recognize fraud and abuse. If you have an older parent, I remember my father calling me and saying that Medicare had called him and they wanted some information from him. And I said, no, Medicare will not call you and ask you things they already know about you. Okay, but that's exactly how these things happen. Is they call, they get those people on the line, they get that information, and then we also talk to people a lot about check your bills, go through them really thoroughly. When my father got out of the hospital after a traumatic fall, when the Medicare bill, it showed up, looked like a small phone book. And so my siblings and I had to go through that process and really try to reconcile that with what we knew had happened with him. MIPA is designed to help particularly low-income individuals make sure they understand what programs through Medicare are available to them. Next slide, please. In addition, some other resources that are available, the Aging Disability Resource Center, the ADRC, it's designed to be a one-stop shop where people can call with questions about anything related to aging and disabilities. The Kansas Respite for Alzheimer's and Dementia Program, it's a program that the legislature funded that helps provide relief to unpaid caregivers so that they can get respite, they can have a break to do the things that they need to do when most of their time is being spent caring for somebody who has Alzheimer's. This is a copy of the Kansas Dementia Roadmap. This was recently produced with KDHE, and it's designed to give guidance and support information to families who are navigating the challenges of caring for someone with dementia. In 2020, there were 55,000 older Kansans who had Alzheimer's or related dementia. When we get to 2025 data, we're expecting that to have increased by about 10%. Next slide, please. Every 4 years, we are required by the Administration for Community Living, as part of the Older Americans Act, to do a state plan on aging. The one we are currently in runs out at the end of September. So we have spent a big chunk of this year working on this with, again, our partners, the AAAs. We've done public meetings, listening tour, online. We had a survey. What we were really trying to find out is what are the biggest concerns for older Kansans and the people who care for them. I'm pleased to announce that the draft of that, the final draft, is finished and will be posted for public comment this week. After 30 days of public comment, we will make revisions, and then it has to be submitted to ACL. It won't surprise you to learn that the issues we heard most about were access to care, transportation, housing, caregivers, and all of those are issues that we address in the state plan for the next 4 years. The multi-sector plan on aging, Deputy Secretary Andrew Brown has taken the lead on this, but it is a 10-year project that we are involved in with a number of other states, again, designed to create a blueprint for how we move forward. One of the things we know is that the aging population is growing. It's the fastest growing part of the demographics in the state of Kansas, currently at 18%. By 2030, it will be 20% of the people will be 65 or older. BOLD is building our largest dementia infrastructure. That's really a KDHE and KDAD's collaborative project funded by the CDC and led by our dementia program manager, Jenny Shipman. Next slide, please. I think there's been a lot of kind of energy and momentum in the field of aging, in the area of aging. Secretary Stanek mentioned Age-Friendly Kansas, the Kansas Health Institute initiative that KDADS is a part of with KDHE, DCF, and others. KU has a geriatrics workforce enhancement program. This is a HRSA grant, and it's designed to help, one, improve through education the health care that older Kansans get, and also trying to deal with workforce issues that we know we're having right now and will continue to have. As was mentioned, the Governor's Advisory Council on Aging, we are in the process of working to get that council reinstated and seated again, hopefully in the next couple months. And then we're actively working on reconstituting the Governor's Annual Conference on Aging. At this point, it's tentatively scheduled for October of this year. And we're working on that with many community partners, the area agencies on aging, KHI, KDHE, and other groups. Madam Chair, that ends my formal presentation. I'm happy to stand for questions.
Representative Carpenter.
Thank you, Madam Chair. So one of the things that I found out last year, which was kind of eye-opening for me, was that through your nutrition programs, you can contract with local restaurants and stuff like that. Could you elaborate a little bit on that? I think I don't know how many people realize that that's available. And there are some of our senior folks, senior organizations that are doing a great job with that. But I just think we need to get word out on that. I was shocked when I found that out that it's available. So could you kind of elaborate on that, please?
Yes, Madam Chair, Representative, one of the biggest challenges, as you can imagine, in a state that is mostly rural and frontier in terms of its size, is that there are a lot of areas where finding providers of service is one of our biggest challenges. Most of the meals were provided in congregate sites and home-delivered meals. During COVID, a lot of that changed, and we haven't seen numbers return to congregate sites like we had seen pre-COVID. But some of the AAAs and the nutrition providers, recognizing that there weren't providers who could go out and deliver meals in certain rural areas, made relationships with restaurants. We had a contract with Hy-Vee where people could go in and get a meal and take it home. But restaurants did the same thing for them. And in some areas, what they're doing is delivering shelf-stable meals for people in really rural areas for several days, frozen or shelf-stable meals to last them several days. It's one of our biggest concerns because we think there's a segment of that population that we're still not even aware of. And I don't think our data on keeping track of what that need is what it should be, and we're looking for more and more ways to, again, work with our community partners to find flexible ways to make sure that we're able to meet the needs and people are getting the nutritious meals.
Well, I know a lot of small towns are having trouble, with their restaurants, keeping them open, and it just seems to me like this is a lot of an avenue for increased revenue and participation and all that. I was just shocked that it was actually available, I thought. So anyway, I applaud that. I just hope we can get the word out to small towns to partner with their senior organizations.
Yeah, I would give a lot of that credit to the AAAs. I think that they know kind of their areas and they've worked in those communities to find available resources and to work with local restaurants. So I think it is a great partnership.
I might just follow up with that. One of the former representatives that brought that to my attention, when he contacted his local AAA, they had no idea that program was available. We were shocked, both of us. And so I don't know how well they know that this is available, but I'm not sure they do.
And I think it's probably driven largely by whether or not they have an area where there's a struggle meeting a particular need. If they already have that being covered by home-delivered meals or congregate meal sites. But some areas, clearly that's been a struggle, and they've started to look kind of outside the box at more different ways of serving those folks.
Representative Bueller.
Thank you, Madam Chair. Thank you for being here. I'm looking at the planning and advisory work groups. I think there's 6 of them in here, and just seeing how our state is aging, I'll try to narrow a question. So I'm interested in addressing healthcare, and if you look at the multi-sector plan on aging in collaboration with several states, I'm not sure if you had mentioned in your testimony when that is going to be completed, but I'm just kind of curious, do you have any key learnings at this point in time that you could share on what we would do different to address healthcare for our aging folks? And that may be from some of the other states. So my reference is, I think we have a proviso in the budget for nursing homes without walls, but I'm curious, what are we going to do different? If the population is doing this and we're going to continue treating with the same parameters, that's not a very good recipe, I guess, for the future. So I'm curious if there's any initial learnings of what we can do different. That makes sense?
Yes, Madam Chair, Representative, that particular program is pretty new. We've actually just started that, only had a few meetings, but one of the things we hope to take from that is being able to learn from other states and what it is that they're doing. I think it is one of our major concerns. I live in Northwest Kansas, and access to care is a real concern, and particularly as we see fewer services available in some of the rural areas. Our commission also oversees PACE, and that is a program that is designed to help meet the need of people who have nursing facility level of care but stay at home. And we would like, in the process of doing a statewide needs assessment, to see if we can expand opportunities for PACE to be available in other areas. It's particularly challenging in rural and frontier areas. But I don't know that I have a really good answer for you other than it is top of our mind as to this is a growing population with growing needs, and we need to be thinking about, and I think some of that is addressed in how we're planning to use the state plan on aging to, in a lot of these work groups, to work together to say, how do we do this in a way that makes sense and that we're all kind of working together and not kind of separate and doing things without knowledge of what each other are doing in those areas.
Senator Petty.
Thank you, Madam Chair. So earlier, Representative Carpenter brought up the issue about home food deliveries and using alternate sources, which I think is a great idea, and I know it is being used somewhat in my community. But along with that I just want your knowledge and thoughts on this. We had some funding in this past year's budget to increase the funding for senior meal programs. So my question is, when you're looking at, whether it's a restaurant or whether it's Hy-Vee or whether it's a congregate site, isn't there still a need to fund that?
Madam Chair, Senator, yeah, the $1 million that we had requested for nutrition funding was in large part to offset a cut that we received from the federal government of about $650,000. We were also aware that there were some people on waiting lists, and we wanted to help try to address that as well. But as I mentioned before, we really want to work with our partners, the AAAs and the nutrition providers, to do a better job of really understanding, do we know all the people who have this need, and are we finding ways to address that? Because I'm afraid that there are some people who aren't at this time currently being counted, but do have those needs.
And just as a follow-up, Madam Chair, so that $650,000, that's not coming back.
We do not expect it to come back, no.
Thank you.
Seeing no other questions, thank you very much.
Thank you.
Andy, welcome to committee.
Good morning, and thank you for your time. I did wanted to say my name's Andy Brown. I'm the Deputy Secretary for Programs at KDADS. And if I could take a second, Representative Bueller, to just sort of address this question. We are planning on working on a waiver amendment for the frail and elderly waiver that would help address and sort of enshrine that pilot project that was the nursing facility without walls. So I think the funding that was provided for that by the legislature this year is really bridge funding to help us continue that pilot project while we're working on the, thank you very much. While we're working on the amendment language. And then we'll need to take that amendment language back to the LCC to get legislative approval for it. So keep an eye out for that sometime in the next year or so. So we are here today to talk about the community support waiver. So this is a little bit of background about the community support waiver. We have a recommendation from the 22 Special Committee on IDD Waiver Modernization to move forward with a community support waiver. The idea behind that is to help reduce the number of people that are on the waiting list for the IDD waiver, because there are people that we believe have a need for services, but maybe not a need for the full array of services that are on that more comprehensive IDD waiver. So we've been working with a contractor to assist with the development of the waiver application. We've also hired some additional internal community support waiver staff. We are moving forward with our intention to help with the waiver, probably about several thousand people. Out of the current waiver, there's almost 10,000 people that are being served, and there's another 4,500 or so that are waiting. We're also hopeful that the community support waiver will offer those less costly services with a proposed $20,000 annual cap per participant, compared with the average annual cost for the IDD waiver of $70,000 per participant. Services might include things like transportation, employment support, personal care, respite, and various therapies. So our update on that is that we will be going through several steps in order to submit in the late fall. Right now, we are working on addressing a corrective action plan that the state is under with Federal Centers for Medicare and Medicaid Services in order to grant assistance to providers. The resolution of conflict of interest for our targeted case management program is important with that, as is our unbundling of day services. We do have work that we're doing around the rate development as well as service definitions. And then we are, based on the 2240 bill, seeking approval from the legislature or LCC if we meet with them after session. The stakeholder engagement is a process that we are currently engaged in. We've also added some additional meetings with InterHab and some other stakeholders to look at their specific recommendations for the waiver. We are working on preparing for public comment and CMS review. And then we'll be looking at what our IT system changes are going to be required for the waiver. Once we sort of started working on these changes within our system, of the IDD system, there was a lot of legislative discussion at the beginning of the session with InterHab, and we're happy to announce that we've been meeting with InterHab now on nearly a daily basis for the last several weeks to really kind of look at how we can look at and explore the recommendations that they were making to the legislature. So we will continue, we're meeting around conflict of interest, implementation of the multifunctional eligibility instrument, and the unbundling of day services. Those three groups have also spawned off multiple subgroups that are looking at specific recommendations. And we are planning to conclude that process at the end of this month so that we have final recommendations to move forward with. So I will take time to stand for questions.
Representative Carpenter.
So Andy, you knew that was coming, didn't you? Pretty much. So big supporter of community support waiver. It's going to be a great thing. I hope to get it done. So I see it's now the application or being submitted is now late fall. And so is that because of the unresolved conflicts on our TCMs, our targeted case management, and our assessment?
Yeah, so we obviously need to have a plan that's going to work for both the state and the providers to resolve those conflict of interest issues so that CMS will consider a waiver application from the state. One of the barriers that we have is that this federal rule has been part of the final rule setting for really the last 10 years or so. And the state has been working towards remedies for that. And in some areas, we already have conflict-free case management. In other parts of the state, we haven't found a solution yet. So the idea right now is to really work on a plan that's acceptable to all parties so that when we come back to the legislature for approval, that we don't have conflict between the providers and the state agencies.
Madam Chair, so originally it was scheduled to be submitted this July. So I guess that gives me more reason to get a fire under you guys to get this damn thing settled before we can submit that. I've been well, I thought we could probably submit that and say that we were going to have conflict-free targeted case management under the community support waiver. But so we went a little bit different direction. We're going to wait for the conflict-free targeted case management and stuff until we submit the community support waiver.
Yeah, that's correct. So CMS will not consider a new waiver from the state, a new 1915C waiver, until we've resolved our conflict of interest.
Okay, I'll be calling Interhab up right now.
Okay, thank you.
As you know, we chaired that committee 3 years ago that kind of put all of this in place. And the frustrating portion for us is I've kept in close touch with Kirk Matthews on the Missouri side. It took them no time to be able to get all of this done. And we still can't figure out why was Missouri able to do it. And it's taking us forever.
So I think the difference might be in the fact that we're currently under a corrective action plan, which includes heightened scrutiny from CMS around our waivers. And I don't think that Missouri was in that situation.
And what put us in that situation?
So the final settings rule, which was passed in 2014, is what requires the state to meet these issues around conflict of interest. But there are additional issues that are on our cap, which include the fact that we have vocational services within our day services. And so we need to separate out and unbundle the vocational services from the day support services. So that's one of the things that we're working on. And then we also have to sort of create a new mechanism for eligibility determination. And that's what that MFEI tool is for.
So the other thing that we found was, I think I can speak for the other members on the committee if they received the same emails that I did from constituents, and you're nodding because we all did, saying, don't let them do this to us. You know, I like where I'm going. Has any of that been put to the federal government? Like, hey, this is what the people are saying. And what'd you hear back?
Yeah, so CMS is very much aware. I mean, the same individuals that are reaching out to us are also reaching out to our congressional representatives and to CMS directly, as well as to KDHE, and the governor's office. So I think that there is a very loud voice that's currently making everyone aware of the concerns that our constituents have across the state. One of the things that CMS has responded to us about that is the letter that was sent to Christine Osterlin at KDHE, which really indicates that the state needs to resolve conflict of interest or potentially face additional penalties.
Other questions, committee? Seeing none, thank you very much.
Thank you.
Madam Secretary, would like to wrap up?
Thank you, Madam Chair. That was the extent of our testimony, and we did have the other written items that are attached to the testimony, but if you have any more questions for us, we're happy to answer those.
And could you outline for the committee what those written items are?
Yes, there's a whole series of written items, starting out with some updates on the PRTFs, monthly caseloads of the NF facilities, updates on PACE enrollment, information about the current HCBS waiver enrollments and people on the wait list, information related to the HCBS enhanced FMAP projects, some things related to state hospitals, related to vacancies and staffing. We've information on the bonus payments that we reported to you last time as well. Some information on mobile competency, reimbursement to counties for folks who are, waiting entrance to state hospitals. Those regular reports we've given your prior meetings, and then just some things that are always written that are things related to like length of stay of HCBS recipients and some particular data around HCBS that we provide, every quarter on a written basis. So that's the general listing.
Madam Secretary, and I know that several of our members have or downloaded the information over the weekend. Are there any questions on that? Not at this time.
Great, thank you.
Thank you.
Thank you, Madam Chair.
Committee, next we will begin the managed care organization updates, and we'll start with Healthy Blue and Brian.
Give these guys a second to get out of here. Maybe they've heard it all before. I'm Brian Byer. I'm the plan president for Healthy Blue. Good morning. It's great to see all of you here today. We do have some slides. I don't know if we need them or not, but I'll just talk through some of the information that's on there. So, Healthy Blue was a awardee for the new RFP for KanCare 3.0. We're very excited to be in the state. I myself have a fifth-generation Kansan and really excited to be part of this program. As you may or may not know, Healthy Blue is a joint venture between Blue Cross Blue Shield of Kansas City, Blue Cross Blue Shield of Kansas, and Elevance Health nationally. And we feel this gives us the best of both worlds, a local presence with the two Blue Cross systems, which we leverage their provider networks and their management teams, combined with Elevance Health, which is one of the largest national Medicaid insurers in the country and is the largest LTSS provider of all the MCOs. To give you an implementation update on the second slide, when I first started this implementation, we know these have been rough implementations in the past. I told my staff and KDHE that my focus for the first 90 days was make sure we did two things, pay claims and answer the phone. And so for the first 90 days anyway, we were successful in those two accomplishments. To date, we've paid 1 million claims. We're averaging about $2.2 million paid in claims per day. So we've gotten the claims part of that taken care of. And then on answering the phone, you can see we've had strong performance there, 18,000 member calls with less than a 10% abandon on the member rate. Speed to answer is less than 3 seconds. And the average hold time, 60 seconds. That average hold time is if the operator puts the person on call on hold to look up the answer. So top reasons for phone calls coming in are for benefits, a new ID card, or to change their provider care, the primary care provider. Oh, thanks. And so those are typical reasons you would expect. There we go. For a call center for folks calling in for health insurance information. On the provider side, total incoming calls, 8,845. Also less than a 10% abandonment rate, very strong results there. Speed to answer is 4 seconds, and the average hold time 38 seconds. So on the first two metrics, and maybe we set the bar low, but knowing this was a complex implementation, succeeded on those two measures of making sure we were paying claims and answering the phone. Now we kind of revolve to that third piece, which is while the plane is taking off, we got to finish building the health plan. So right now our focus is ongoing work on provider credentialing, data integration, and getting the EVV systems working and compatible with the state systems. In terms of our network, in large picture, our approach, we know Medicaid is not always the best payer. And so to get providers willing to participate in the Medicaid program, really two approaches that we push here. One is administrative simplification. reducing the amount of provider abrasion it takes to work with the MCO, making it easier to get prior auths, making it easier to deal with the MCO in terms of claims issues, and then communications, making sure that we are available when they have a problem. We have provider relations reps all throughout the state. I've given a number of providers my personal cell phone and email so they can get a hold of me if they have problems, making sure that if there is a problem, they do have someone at Healthy Blue they can contact to get those resolved. And, you know, in Medicaid, and with an implementation like this, there will always be problems, and we want to be known as the health plan that jumps on those quickly and works to work with the provider to take care of them. In terms of the network status, right now we're at 48,957, and that is actually as of March 1. I was hoping to get the April numbers for today's committee, couldn't get them in time because I'm at our trend rate, I'm assuming we're about 50,000 now, and that's getting the providers through the contracting, credentialing into the KMAP system and loaded. Just takes a little bit of time, so that number will continue to inch up. And you can see on the right-hand side, the primary care count, 6,193 providers, and our goal on the PCP side is to have the largest PCP network in the state, so well on our way there. So that's the update on implementation. I can answer questions now or at the end, whatever's most convenient for you.
We'll take them now. Committee, do you have any questions for Healthy Blue? We may have questions after we hear from all. Oh, yes, I'm sorry, Representative Carpenter.
Thank you, Madam Chair. So how many folks did you end up with out of this?
Members?
Yeah.
Around 112,000. Number kind of moves daily.
Just curious, in the big switch over, 112,000. Okay.
112,000, right.
Good. Thank you.
Representative Ballard.
Thank you, Madam Chair. I mean, being the newest one, you had like the lowest number. One of the things I've often wondered is we talked about it many years ago when we set up the three, that it would be a third, a third, a third, knowing that you can't quite do that. But what did you do to make sure that people knew what your services were and what you were going to provide?
Again, obviously, we're less than a third. I think we're at 28, 29%, so we'd like to see a third, a third, a third. And we were part of all the promotional materials that went out from the state. Also did some radio during the open enrollment period. One of the issues we had was as we went through the enrollment, it takes a while to get the provider systems up. So we would have providers who are contracted but not showing up as in-network, either in the KMAP system or in our system. So we had a lot of members disenroll due to the fact that they didn't think their provider was in-network when they were. So hopefully, you know, as those systems get fixed and people call in, they'll realize the provider really is in the network. We're gonna, you know, our goal is to have the largest PCP network in the state. I think we have 95% of the primary care providers in the KMAP system in our network. Just got them to show up on those tools that the members use. So I think that will help. The other disadvantage we have is, you know, is Aetna lost a contract, they really kind of lost that motivation to keep their members. And so their enrollment kind of went down, and what we inherited was primarily Aetna numbers. So really those two factors are what drove to a lower than anticipated enrollment.
Excuse me, would you say at this point you're sort of satisfied with the progress you have made based on all the other factors?
Yes, yeah.
Okay.
And we would anticipate, right, as we get those system issues solved in our system, and we're obviously motivated to get them fixed, that the fact that we have the largest provider network, the fact that we're providing superior service, that will start to work and those numbers will recover.
All right. Thank you very much. Thank you, Madam Chair.
Representative Sutton.
Thank you, Madam Chair. Maybe you can just help me understand what you wrote here is really what I'm looking for. On the unique provider count, I see 49,000, but then when it's broken down on the right side, it adds like 14,000. What am I missing?
And the math don't add up, right?
Well, I'm sure I'm missing something. I just don't know what it is.
Yeah, when we were asked to put together the slide, we talked through the other MCOs in the agency about what they wanted to see, and there's actually probably like 45 provider types. So there's only the representative sample of the most commonly asked about provider types on the right-hand side.
Gotcha. Okay, well, that makes a lot more sense then. Would it be possible for me to get the full list?
Yeah, absolutely.
Excellent. Thank you. Thank you, Madam Chair.
Representative Bueller.
Thank you, Madam Chair. I think I'm going to ask this question to all three of the providers when we speak to them. I'm going to refer to, without names, some of the written testimony we have. Could you send us, I'm interested in if you have a client who has a condition where they need a technology assistance, a customized wheelchair, cerebral palsy. Could you tell me what your practice is in terms of working with a client to make sure that they're not denied over and over again? I'm trying to understand how, or if you've got any statistics that say, we've got this person with this need for this chair, and yet they get a first denial, a second denial, et cetera. So how would you respond to that?
Yeah, and I don't know the facts of the case, really. So initially, what's going to happen with that is it's going to be a medical necessity determination of what level wheelchair they need, right? So without knowing some of that specific facts and having that medical case, it's really hard to say.
So in general, if a person was in a chair and they outgrew the chair, how would you handle that?
Again, it depends on the facts of the case because it's based on medical necessity criteria, which may change, and their conditions may change.
Thank you.
Yeah.
One moment, Representative Ballard. Thank you. Committee, a couple of you are texting me regarding, you may remember at our last meeting, we were putting together a list of we would like for the MCOs to respond to XYZ. That will go in, we are still compiling that, so that will go into our next meeting. That's our 2-day meeting that'll be coming up in the summer. And so please continue to put that together. And I think Senator Erickson, you had something you wanted to add to that.
Yes, thank you, Madam Chair. I would like to add to that list to Representative Bueller's point. I would like for each MCO to report the following related to complex wheelchairs on a monthly basis. First of all, the initial prior authorization denial rate. Second, the average and median time it takes for final approval of wheelchairs. And this data should be broken out, I would request, between complex wheelchairs ordered by therapists employed by certified seating clinics and therapists outside of the certified seating clinic system. So that would be my request, Madam Chair.
Happy
In
to.
committee, if there are other requests like this, and I'm sure there are, please get those to me so that we can compile them, and then we'll get them to the MCO, so that'll be ready for us at the next meeting. And Representative Ballard.
Representative Erickson actually asked my question. She just added more to it. More specifically, but I was interested in it because, maybe because we had, especially with social services, people talking to us about it and how complex their wheelchairs are. They're not just the regular wheelchair that, you think there's so many things. And basically they live in their wheelchair. So it's like that, it's their home in so many ways, and they can't function without having all of those things. So I think that's one of the reasons why we're being more specific about it, because otherwise they're not mobile and they can't do a variety of things. And some individuals or some companies are making it very difficult for them. So I think between what I was going to ask and what Representative Erickson, it was pretty comprehensive. So thank you very much, Madam Chair.
Happy to look into that.
Representative Bueller, were you finished with your question?
Yes, thank you, Madam Chair.
Additional questions? Seeing none, thank you very much. Committee, next we have Sunflower and Michael Stevens.
Madam Chair and members of the committee, I'm Michael Stevens from Sunflower, and I have two other members of our team that I'd like to introduce who will be presenting. First is Jamie Price, who is our Senior Director of Network Development.
Welcome, Jamie.
Thank you, Chairwoman Gossage, Vice Chair, members of the Bethel Joint Committee on Home and Community-Based Services and KanCare Oversight. Thanks for having me this morning. Today, I'm going to update the committee on Sunflower Health Plan's provider network, including the current landscape of contracted providers, customer service, operations, and my co-presenter, Michelle Baller, will present on claims information. But before I started, I wanted to share a member mission moment. Our CEO, President Michael Stevens, has created a culture at Sunflower Health Plan where we start meetings and events with mission moments. This anchors our conversations on the plan's core values, compassion, health equity, and service. And it ensures our member mindset, first mindset, is at every level of the organization. So this morning's mission moment highlights our member, Linda. She has struggled with diabetes and as a member of the Cheyenne Nation, has been a longtime resident of Hayes, calling it home since 1968. She is always seeking the right healthcare support to manage her health and diabetes. Recently, she made a switch from an MCO that is no longer participating in the Kansas Medicaid program to Sunflower Health Plan. This switch to Sunflower Health Plan was at the recommendation of her trusted eye doctor, Dr. Wallmeyer, who spoke highly of Sunflower and he is one of our network providers. Linda attended our rural health event in Hayes after receiving an invitation from her care manager, Kimberly Reel. She was the first person to sign up for vision services at the event. Kimberly had spent 4 hours with her a few weeks prior to the event, enrolling her in care management, assisting in setting up her PCP, and developing her care plan focused on her working to better understand and manage her chronic health conditions. While she expressed previously appreciation at the $25 over-the-counter benefit from her previous MCO, she expressed appreciation for similar value-added benefits that Sunflower Plan offers, including the upcoming rural health event and the provider network. She arrived at the event utilizing Sunflower's transportation provider, SafeRide. Linda expressed one of her biggest surprises from the event was the presence of Hy-Vee. She shared that her age, getting access to fresh produce is often difficult, and seeing Sunflower partnered with Hy-Vee to bring high-quality food directly to the members, in her words, was a blessing. It was something she had not seen other organizations do. While at the event, Linda had a health crisis. Her blood sugar spiked to 400, a dangerous level, and she was immediately supported by Sunflower Health Plan team members, many of which are trained nurses. Thankfully, with the support of the team, Linda recovered safely and went home. Later that day, she called our Director of Health Equity to share her positive experiences at the rural health event. She expressed appreciation for her care manager and the manager of community relations who had provided her with many resources at the event. Her story is a testament to trusted providers, community engagement, and a health plan that truly cares. At Sunflower Health Plan, every member matters, and every story like Linda's is a reminder of why we do what we do, and why all of us do what we do. I wanted to share a little bit about our provider network next. Someone else, oh, perfect, thank you, appreciate that. We have 27,779 currently active providers. Some of that provider breakdown, which it's not the full provider breakdown, much like with United, we have 4,682 primary care providers, 773 pharmacies, 835 HCBS providers, 473 dental providers, 468 optometrists, and 152 transportation providers, with SafeRide being our new transportation vendor. And then I broke it down a little bit more by member access, by specialty, in both adult and pediatric. So with our adult specialty access, you'll see that 100% of our members have access to gastroenterology, hematology, oncology, nephrology, otolaryngology, I always get that one wrong, pulmonary disease. Over 99% of our members have access to psychiatry, dermatology, urology, and dental services. And our high access rate of 98.9% for physical medicine and rehabilitation, 93.9% for allergy, and 93.9% for reconstructive surgery. Moving on to our pediatric specialty access, 100% of our members have access to gastroenterology, nephrology, and pulmonary disease. And 99% or greater of our members have access to dermatology, hematology, oncology, psychiatry, and urology, with strong access with physical medicine and rehabilitation at 97.9%, allergy at 96.6%, and plastic and reconstructive surgery at 92%. And then we're working on improving access to dental at 86.8% currently and neonatology at 81.9% currently. These results reflect Sunflower's active provider engagement strategy, our robust contracting efforts, and continued focus on improving access in historically underserved pediatric specialties such as dental and neonatology. We remain aligned with KanCare's network adequacy standards and continue to invest in provider recruitment, telehealth expansion, and innovative partnerships to close the remaining access gaps. And move on to our customer service metrics. In January of 2025, Sunflower handled 12,129 Medicaid inbound calls from members and providers, meeting and exceeding all regulatory and performance standards. We launched a provider chat functionality in February 27th to be exact, expanding access to real-time support. And as of March 31st, Sunflower serves 148,602 members with 35 dedicated customer service agents supporting both members and providers. And the next slide will go to some of the metrics. The metric of our service level metric, our goal is 80%, and our actual was met at 97.5%. Our average speed to answer is 7 seconds, with our goal being 30. Our quality post-call audit score is 95.3, 95.3, and our goal is 95%. First call resolution is at 91.4%, with our goal at being at 85%. And customer satisfaction post-call is at 95.5%, with the goal being 90%. I'm going to let Michelle speak next, and then we'll stand for questions. Thank you.
Very good. Welcome, Michelle.
Good afternoon, Chairman, Vice Chair, and members of the committee. Thank you for giving me the opportunity to appear before you today. My name is Michelle Buller, and I serve as Senior Director of Operations for Sunflower Health Plan. I'm here today to talk about Sunflower Health Plan claims operations. So our year-to-date through February average turnaround time for claims payment from receive date to paid date is 8.46 days for our providers. Our percentage of denied claims cumulative this year-to-date is 14.62, which is actually an improvement related to previous year-to-date cumulative of 17.85%. Our auto adjudication rate for claims is 95%. What this means is it auto adjudicates through the system with no manual manipulation needed. And then 99% of our claims are received electronically. We only receive about 1% of our claims receipts via paper. Thank you, and I will pause for any questions.
Questions committee. Representative Ballard.
I'm sorry, I was following you. You say you only receive 1 point whatever in paper claims. Would you explain that again?
Yeah, about 99% of our claims when submitted by providers are done through an electronic means. So electronic through a clearinghouse or a web portal. The 1% of paper is providers actually printing off a paper claim and mailing it in.
I was looking at you and I don't know where my brain went, but I was thinking you received that, but you were saying just providers.
Yes.
But you still allow consumers or anyone else interested in services to file their claims?
Members don't file directly to us. As an MCO, the providers file on their behalf.
Oh, gotcha.
Correct.
So they only go through their MCOs.
That is correct.
I wanted to make sure I had it straight.
Yes.
Additional questions, committee? Senator Erickson.
Thank you, Madam Chair, and I believe this is for Jamie. Jamie, on one of your slides, the pediatric, I apologize, in my former life, I was a business education teacher. My proofreading skills, I can't shut them off. But on your chart, if we go back to the pediatric. There we go. Nope. Yeah, there we go. There we go. So all of them seem to be in numeric order except for urology. Is that correct percent for urology?
It is a correct percent, probably just slide layout problem.
Okay.
No, you're correct.
I just want to make sure I've got the right data. Thank you.
Additional questions, committee? Representative Bueller.
Thank you, Madam Chair. And I might ask upon Senator Erickson if you would restate what we did on your requirements on the previous conferee. Again, back to complex wheelchairs. It just seems to me this individual we're talking about, lifelong, been in a wheelchair, complex wheelchair her entire life, and deny on resizing. So I'm just curious if Senator, if you wouldn't mind restating the expectation to provide information back to us. Thank you, Madam Chair.
Absolutely. Senator Erickson.
Thank you, Madam Chair. Yes, that each MCO shall report the following related to complex wheelchairs on a monthly basis. Number 1, initial prior authorization denial rate. Number 2, the average and median time it takes for final approval of wheelchairs. And this data needs to be further broken out between complex wheelchairs ordered by therapists, employed by certified seating clinics, and therapists outside of the certified seating clinic system. Thank you. You're welcome.
Representative Ballard.
Thank you, Madam Chair. That raised another question for me. Cost. I just want to make sure I have it clear. I was told that that wheelchair could cost anywhere from $85,000 plus. Is that, do you know what it is? Because I've been trying to figure out why is it so difficult when you have a person that's been in this chair all their lives. Now, everybody knows people grow. They expand sometimes, they shrink sometimes. It depends, whatever it is. So I'm trying to figure out what is the problem. Is it really the cost?
I am actually going to have to take that back to confirm because I know we have a medical necessity approval process for all of the wheelchairs, depending on the different cost and the complexity of the wheelchair. So I would have to take that back and get some information back to you about average cost of the different types of wheelchairs along with accessories.
Would that be additional information that would be helpful? Average cost, including accessories, complex versus non-complex? Okay.
I would think so, as well as a regular, I'm trying to make sure I understand it because it's very complex, but not only those, but in terms of, well, you said accessories, but the type of wheelchair we're talking about. Because when I think of a wheelchair, I think of the ones that people just get in and get around and move around. But as I said before, these people live in those. And so I think that has a lot to do with the cost and the complexity of all of that. And the individuals that are into me says they're not sure people really understand that they cannot have any kind of quality of life if they don't have all the things they need in this wheelchair. Okay, so I want to just make that clear because I told them I would do the best I could to articulate that. And because I don't live in my wheelchair, but I have other things I need to have in order to have quality of life, I want to make sure that they have that quality.
That makes absolute sense, and it probably falls down to that accessory, right? You have that basic wheelchair and then those accessories, so we can get the...
Thank you very much, and thank you, Madam Chair.
Brett, I saw you nodding your head, Brett, with Blue Cross. Is there something you would like to add? All right, very good. Thank you, ladies. Committee, next we'll go to United Healthcare.
Thank you, Madam Chair, members of the committee. My name is Jenny Ismert. I'm the CEO for the Community Health Plan of Kansas. So really appreciate the time today. For our time, we really wanted to spend some time highlighting a collaboration with the KU Medical Center and a project that we worked on, Project ECHO, which was a partnership between United Healthcare and KU Medical Center. So Project ECHO, I think part of the reason we wanted to highlight this is that it's really was a collaboration on community education of the care delivery system, really centered around the priorities that have really been laid out by KDHE as well as this committty. Antipsychotics is a really good example of that we talked about earlier today. So Project ECHO, which is it stands for Extension for Community Healthcare Outcomes, is a telementoring program that uses video conferencing to connect healthcare providers and subject matter experts, creating virtual communities and learners, improving access to specialized care in underserved areas. So I'm actually going to invite Dr. Shauna White, who's the director of the KU Center for Telemedicine and Telehealth, to speak a little bit about those efforts with Project ECHO.
Good morning, Madam Chair, committee members. My name is Shauna Wright. I'm the director of KU Center for Telemedicine and Telehealth, and we are home to the Medical Center's Project ECHO Hub. We were thrilled to have the opportunity to work with United Health in delivering a series of training opportunities for healthcare providers and even our public health departments during the last year and a half. I'm going to scroll here. This included the opportunity to address several issues that I believe are healthcare priorities for KanCare as well as United Health. We reached healthcare providers across the state. We did a school-based mental health echo where we invited in school districts from across the state as well. And we, of course, engaged our public health departments in some of our projects. We could go to the next slide, please. We had 5 different topics. The top topic there, the school-based mental health, was a academic year-long echo where we engaged school nurses, psychologists, social workers, as well as counselors in addressing their needs in their schools in that domain of behavioral health. We did a needs assessment before we started, so we made sure to address the topics that were most pressing and important for them. One of the things that I'll add about Project ECHO is that it's not only a delivery of content by subject matter experts, but we ask our learners to bring in their tough cases. So within each session, not only do they receive didactic training, they bring their tough cases, and then that specialty team wraps around them to help them address the needs of the patients or students that they serve. We had 4 short series echoes that included lead poisoning, antipsychotic use, and non-pharmacological behavioral health interventions for older adults, health equity, and then maternal health as well. I won't read all of the numbers to you. ECHO is a very popular learning modality here in the state of Kansas. It's actually a global initiative that has pretty wide response. Part of the drive for that is that when we are funded, our funder covers the cost of continuing medical and nursing education for those who participate. So they do receive those credit hours at no cost to them. We wanted to highlight a couple of the projects that we did. If we could move to the next slide. I will tell you, lead poisoning just kind of blew my socks off. We've been doing ECHO at the Med Center for a little over, almost 10 years. And when United Healthcare said we want to address lead poisoning, I thought, oh my goodness, who's going to show up? How are we going to make this happen? We knew that people would show up, but this program broke records. It's been our most record-breaking program in terms of registration and participation. Human Health Services Region 7 reached out when they heard that we were doing this project. They asked if we could invite all of their region to this training opportunity. United Healthcare opened the doors and said, absolutely, if learners need to come in, allow them to come in. Since that time, we've transitioned those materials into enduring materials, meaning that even though our live sessions have been completed, people can still access the training and receive continuing education for that training. There were some, I believe, grants that went out through KDHE to local public health, to Kansas level public health departments. And as they received their grants and received equipment to test for lead poisoning, they asked their public health departments to attend this training if they hadn't already. So it's still being utilized quite a bit. And then the next project, if we move to that one, please, was our mental wellness echo, which focused on reducing antipsychotic prescribing for older adults and also addressing the increased use of non-pharmacological and behavioral interventions with that population. We had a very robust specialty team there and a great turnout. This was one of our favorite projects in the last year as well. I will stand for questions if there are any.
Senator Erickson.
Thank you, Madam Chair. Just quickly, can you explain kind of the overlap, or is there any, between social determinants of health and ECHO?
I think that a lot of the work we do is informed by social determinants of health, just in terms of we are reaching across the state, but many of our participants are from rural and frontier areas where they may not have the same resources available to them, even as our specialty team. We do make efforts when we build specialty teams to include rural providers that are subject matter experts, but I think that those issues do come up in terms of meeting the needs of all Kansans. Not every county or community is as resource rich as our more urban areas. So I believe that we have to keep that in mind with all of the echoes that we do in terms of making sure that providers are aware of the resources that are available to them, and even that our specialty team members learn about how rural communities innovate around determinants of health when they aren't easily accessible in their communities.
Thank you, Madam Chair. And I have just another question. You mentioned funding. What is your funding source for this program?
It varies. So Kansas is very different than some of our neighboring states. For example, Missouri receives funding through their Medicaid program directly. It's a part of their legislative process. Our program is different. Primarily our funding comes through grant sources. So if there is a HRSA grant or a SAMHSA grant, and that project team wants education for healthcare providers to be a part of that, they will contract with us and we'll build an ECHO. We do quite a bit of work with KDHE on their healthcare priorities as well. For years, we worked with them with addressing substance use disorder and improving pain management. We have stepped into the world of infectious disease with KDHE, including HIV treatment, as well as others. We are looking forward to working with them hopefully next year as we're welcoming the World Cup to our area and looking at how we can address medical needs for any kind of infectious disease that may come with international travelers. We seek our own grant funding, but primarily we are funded as part of other people's or other groups' grant projects. And then, of course, there have been times where we've worked with the MCOs. We had a generous grant from UHC to address their healthcare priorities. And in the past, we had also worked with Aetna.
Additional questions, committee? I do have a couple, and one, did I miss it? Did you answer the question regarding the wheelchair that was asked from the other two? Or is that's going to be you? Okay.
Yeah. Hi. What specific to,
Yes.
Okay. Okay. Yes, I'm aware of the additional data request. Happy to supply that information as well. And then, to echo much of what our other MCOs have said, we have a medical necessity process that we follow. I think anything that you can share about this individual case would be extremely helpful for one of the MCOs as well, so that we can take a look into the details of it.
May I? A young lady who was born and is a cerebral palsy and some other brain conditions and been in a complex wheelchair her entire life. Born in about 2008, so the current wheelchair she's in was purchased in 2019, and so it got to the point where she had outgrown it. And so as she had gone through the seating clinic and all of that, her first and second response was deny. Why do you need this from the insurance company? That was in, let's say the July timeframe of a year ago. The denial led to bed sores and other debilitating conditions that put this young woman into the hospital, fighting for her life. So what could have been maybe addressed through a new wheelchair where she wouldn't have had bed sores and other things might have prevented some of the other stuff. So so it seems to me that the medical necessity part of it is really not. It's been proven it was medically necessary. It was a medical necessity, but the denial led to many other negative consequences. So that's the reason for the question.
Thank you for that. I appreciate that.
Sure.
Yep. Okay. Thank you.
Additional questions, committee? I was looking through, I had made a personal request on behalf of the committee at our last meeting, asking each of our MCOs to break down their population categories. And I received that. And then also I'd ask about the dual eligibles and the aligned members. I received the aligned members from one of the MCOs, but not the other two.
Okay.
So basically the breakdown would be how many dual eligibles do you have? And then how many of those have a Medicare Advantage plan, which is what we're talking about here, which would be aligned with that members organization.
Okay.
Is that clear?
Yes, that's clear.
Thank
I
you
will
very
follow up with
much.
that. Thank
I
you.
appreciate Sunflower doing that for us.
Thank you.
Additional questions, committee, before we move on? Seeing none, thank you all.
Thank you.
To the MCOs, and again, we will get that total breakdown for you. I do have a question for the secretary before you leave. Oh, you weren't leaving. You, okay. If you could come up to the mic. You know, when, with an employer group, we receive a detailed monthly information about numbers of claims, types of claims, PBM report, cost of, you know, not members' names, but cost per members, et cetera. Do you receive that sort of detailed breakdown from the MCOs in the department?
Let me ask the other secretary as the
Okay.
Medicaid agency. Yeah, I mean, and we share information that they receive.
Okay.
But I think that's probably best.
Great, thank you.
Yeah,
Thank
those
you.
are all things we get on a regular basis, and
I'm
they're,
sorry.
those are all things that we get on a regular basis and are broken down. Mhm.
Thank you.
Uh-huh.
Committee, we are now ready to move to our legislative history of KSA 39-7160, and Elizabeth will explain to us why this is requested.
Well, it was requested that KLRD do a memo about the legislative history of KSA 39-7,160, which is the statute that formed the committee that you all currently serve on, the Bethell Committee. So you received in your packets the memo from our office, and I'm just going to do some highlights. There have been 3 pieces of legislation that have created this committee, and then the memo includes hyperlinks to all the legislative history, so you can go look at the testimony and whatever from each of the sessions. So,
Elizabeth, I'm going to ask you to pause for just a moment. Everybody just received paperwork they're
yes,
filling out. I want to make
to
sure they
sign.
can give their full attention to what you're telling us. Okay, I think we're ready.
All right. So the committee was initially created in 2008. And if you go to the bottom of page 4 of the memo, you will see that the Oversight Committee was directed to do 6 things. They were to review the number of individuals transferred from institutional settings to home and community-based settings and the associated funding, review community capacity and ensure adequate progress was being made for the transfers to occur, study and determine the effectiveness of the program and perform a cost analysis, review the salaries, benefits, and training of direct care staff, review and ensure that any proceeds resulting from the unsuccessful transfer be applied to the system of long-term care and home and community-based services, and review the Legislative Budget Committee report to the 2007 Legislature regarding funding recommendations for home and community-based services, and use of the report as a guideline for future funding and policy recommendations. And then in 2013, the committee was renamed in honor of the late chairperson, Robert Bethell. The legislation expanded the scope of the committee to add 4 more items. So those are on page 6. So the expanded scope was to monitor and study the implementation of and operations of the HCBS programs, the Children's Health Insurance Program, the Program for All-Inclusive Care of the Elderly, or PACE, and state Medicaid programs, including but not limited to access to and quality of services provided, and any financial information and budgetary information. And also in 2013, the committee membership was changed. The meeting days were changed to one day one day in January, one day in April, and at least one day in each of the third and fourth quarters, not to exceed 6 meetings a year, and that 6 members constituted a quorum instead of the 5 members previously required. It allowed for it required a committee report to be submitted annually and set minimum report requirements, which are listed on page 7 and 8 of the report, and permitted the committee to introduce legislation. The third change to the committee structure occurred in 2015, which again updated the membership and the meeting days in the third and fourth quarters to 2-day consecutive meetings. So those are the highlights.
One of the reasons I ask this to be brought to our attention is that it is increasingly difficult to try to have a meeting in January. We've all just come back to the Capitol. You remember this year it was everybody was tied up in Ways and Means, and I'm like, do we have any committee members? Elizabeth, let's try to find a time. And we ended up having it in February, the first week of February or the second week of February, because in January was just out of the question. So I'd like for you to take a look at this memo. We will speak at our next committee meeting about potentially changing that regulation or that requirement that it has to be in January, and perhaps have it just be the first quarter as it is with some of the others. And anything else that you would like to take a look at as to the purpose of this committee? Elizabeth? I'm sorry? Yes. So next we have Sean Gatewood.
There we go. Now it's on. Madam Chair, members of the committee, thanks for having me today. I feel a little odd about not talking about KanCare itself, but talking about this committee. And I didn't get a chance at the end of session with the chaos of session to sort of catch up with the chair and talk about, the purpose of this. But I saw the opportunity. I wanted to stand up sort of for 2 things. One, I think that the engineering of this committee is unique and important. That it marries House and Senate, Republicans and Democrats, policy and budget to oversee this, program that has a breadth unlike any other in state government. Just so many pods, so many complexities. And so this committee brings all those folks together to provide leadership when issues arise, to move things through. All the parts are there to be able to make this program as good as it possibly can be, identify problems and overcome. So I want to just sort of stand up for that. And the other thing is, I would like to see if there are any changes, and there may be, the consumer and provider perspective. We've had so many instances over the years, including one that Representative Bueller's brought up a number of times today with the wheelchair access and that issue. And that came up in this committee. And if I go back through the past, decade plus of this committee, those things arise, and this is just a great place for folks that are experiencing those problems. And you get to see it as sort of a systemic issue. You can take care of it either systemically or if that person's having an individual issue, they can come to you. And I've seen those problems taken care of time and time again through the leadership on this committee. So for what it's worth, I think the committee was engineered well. And I think it addresses problems. If we want to talk, or it's obviously your decision, if you want to talk about how to, streamline things a little bit more, that's great. We just want to make sure that we have adequate access for the providers and the consumers that are impacted by the program. And thank you very much. I'll stand for questions at the appropriate time.
Any questions for Sean, committee? Seeing none, thank you, Sean.
Thank you.
And next we have Haley.
We can't hear her online.
Mics? Is that any better? My apologies.
Yes.
Okay. I believe that was Senator Petty. Thank you. All right. So just to reiterate, what our office with the state long-term care ombudsman really wants to reference to is the transfer from state or private institutions and long-term care facilities to home and community-based services and associated cost savings, other outcomes to the money following the person. So we have experienced over the last 9 months a couple of recent closures of homes that have either voluntarily surrendered their license or that CMS terminated their license. And what we have found is that there have been several individuals that have been able at that time when the situation prompted them to discharge and live in the community. So one of the resident rights that we really focus on is the right for the person to live in the environment of least restriction in the setting of their choosing. And if it's brought up with a closure that we can coordinate it, our office just views it as, why can't we look at that more routinely? One of the things that should be happening frequently, quarterly, if not more frequent, is in like skilled nursing home settings, they should be reviewing a discharge plan if the resident is wanting to discharge to the community. And really, we don't see that there's a lot of oversight on that. That is something I know state surveyors can look at. We get called in and we try to come in and help coordinate that, but that's on a resident complaint or a family initiated complaint. Otherwise, I know that the MCOs, I believe the requirement is annually, if not more frequent, to be looking at that. But that is something that we do run into frequently, and I want to bring that to a point of your attention. And the last part that becomes a little bit of an obstacle with that is adequate housing. I know you guys probably hear about that a lot, but when we find these individuals that are wanting to discharge from nursing home, from assisted living, and maybe they had a temporary health situation that allowed them to move in for that time, but circumstances have changed, and now they're wanting to move back into the community. A lot of them are income-based. And so, HUD and things like that, we do run into some issues of adequate resources to be able to support that and help. So I know there's some oversight opportunities there, but I just wanted to bring that attention from our office on complaints that we get related to the relevance of this committee.
Thank you very much. Questions, committee? Seeing none. Thank you very much, Haley. And next we have Heather Brom. Sorry, I saw her here and just thought, well, she's in the room, so we'll give her a chance to tell us.
I don't have much prepared, and I still sound horrible from being sick, so I apologize. Really, just we wanted to point out to you all the suggestion of creating subcommittees for this committee. KanCare deals with a lot of different populations, and when I look at the last 5 years of attending these meetings, there's a lot of time spent on certain populations, but not others. And from our perspective, obviously, 60% of KanCare's enrollees are children. And so a way to look at them more, get more into depth, is subcommittees. And yes, that does lead to more meetings. But, thought back to the mental health modernization process that happened a few years ago, and how you had stakeholders involved in facilitation and a lot of outside meetings, but where you had the opportunity to gather and hear from a lot of different stakeholders and learn more about those populations. You have the rest of my testimony. I won't go into what's written there, but that would be the one thing I would raise to you all, is the consideration of, as complex as this program is, yes, it would be more time, but if you want to give more oversight, look into things more and take more opportunity to hear from
I
folks.
appreciate that. Thank you, Questions Committee. And I would just mention, as you know, we do have the Child Welfare Oversight Committee as a separate committee than this one. And sometimes there's some overlap there, but I appreciate it. Thank you very much.
Thank you.
Committee, that's all we have for today. Unless there are any other questions, I'm just going to share announcements. Yes. Okay, Senator Petty, did you have a question for us?
I did. So, Madam Chair, I know it's so hard to recognize when we're online, but so I appreciate the update on the legislative update from Elizabeth on KanCare oversight, and then the speakers who spoke. So my question is, are we then looking at our next meeting? I mean, I know you mentioned potentially some sort of changes, but I'm guess I have two questions here. One, were we talking about changes in the possibly when we're meeting, and also expansion of the scope, but both those things, wouldn't they be legislative?
I agree they would be. It's just, I wanted the committee, it's been a while, to be able to look at how was it first formed? What are we supposed to be doing exactly? And just the breakdown. And then again, regarding how the meeting was structured, the meetings are structured. And that leads me into committee. The third quarter meeting will be July 14th and 15th. Those will be all-day meetings. And then the fourth quarter will be October 13th and 14th. Again, those are required all-day meetings. And we will have more discussion about potential change of that January meeting is one that I would like to discuss with you. Any other questions or comments? Representative Carpenter.
Thank you, Madam Chair, and I really appreciate this update on and what we do. Bob Bethell Oversight Committee, that's the first time I've ever seen it. So I'm glad to know that I've been kind of following the rules a little bit. So thank you for that.
That always helps, doesn't it? And Representative Ruiz, do you have the last question?
Yes, thank you, Madam Chair, and thank you so much for having the memo about the history of the committee. I didn't see anything in there that speaks to public comments and any kind of rules, policy, or anything related to public comment. I have received several complaints from constituents who felt like it felt like to them that it suddenly turned into written only, or they're only given 1 minute to speak. And one of the things that I really appreciate being on this committee a lot is the fact that not only do we look at numbers, but we get to see and hear the faces to the numbers. We get to hear, things about all of the issues regarding wheelchairs that I was never aware of until folks started coming to the committee and in their wheelchairs and to talk to us about what it's like, to be able to function and live their best life with the use of a wheelchair. So I told folks that I would bring this up and that I would advocate that we have a certain portion dedicated to the public comment. I know, Madam Chair, with the kind of all of the aspects of the committee that we need to hear. I think for me, that is the most important. And so I'm just advocating that we move away from written only and have a public comment, or if we can have a discussion at a later date that the committee can just kind of try to hash this out. Thank you, Madam Chair.
And I appreciate that, and that's something that we can bring up at our next meeting, Representative Ruiz. As you know, as a chair, we have a certain amount of time and trying to fill everything, and sometimes you have no idea until the day before what testimonies are going to come in, and you allowed a certain amount of time for that, and there could be 30, there could be 5. And it just makes it very difficult to know, but always try to give everyone an opportunity who was there to speak, an opportunity to speak. But that's a very good point, and we will add that to something that we can discuss at our next meeting in July. Committee, any other questions?